This conference will now be recorded.
Okay, so what we will be doing in the class today will be like a little basic about colposcopy, about smear. Then what the update has come in the guideline, updated 2020 February guideline. Then what are the updates are there in HPV vaccine. So there are these things will be covered in the class today, and it is useful for both part 2 and part 3 people. Why? Because in last year there had been in both of the exam in April and in November a question from colposcopy smear has come. Both in both exam station was there, so it is important to know it very well. And as the guideline has been updated, so it becomes important for upcoming exam as well. Okay, so starting with the little basics. So actually, this you already know that there is a ectocervix and endocervix. So ectocervix is lined by non-keratinizing stratified squamous epithelium. Okay, so everybody knows this. Endocervix is lined by mucinous secreting columnar epithelium. And whenever there are changes occurring in vaginal pH, so it will go into squamous metaplasia. So because in the vaginal pH so many changes are occurring, so this metaplasia is a common event. Okay, so it keeps on happening that because of the changes in the vaginal pH. So this is the very simple basic thing, but again for part 2 people it is important, because you can be asked the question from the ectocervix lined by non-keratinizing stratified squamous epithelium, and endocervix lined by mucinous secreting columnar epithelium. These are the two questions here. Apart from this part is important to understand. So whenever there are changes in the pH is occurring, so there are changes in the vagina. Because of these changes in the vagina, there occurs squamous metaplasia. So these are the changes in the cell, and this squamous metaplasia, it is because of the changes in the cell, because of the change in the pH, so it is physiological. Okay, so this part is a simple thing. But what happened on the other side, if these cells they are occupied with this HPV virus, then instead of going to this normal change of squamous metaplasia, the cells will go into dysplasia, and these are the dysplastic changes, and this is considered to be pathological. Okay, therefore we always say that HPV is responsible for all the changes that those are happening in the cervical cells, therefore it is pathological. Now this is also important to understand people why the guideline has changed. So previously in the guideline they were primary thing what they were doing was smear. Okay, so they were trying to find out all these changes in the cervix. But now what update has come in the new guideline, instead of checking for their cell, they have moved ahead a step. Now they want to check here HPV. So they want to check at this step. In previous guideline they were checking the woman at this step. Now they have become more advanced, so now in the new guideline this HPV they want to check. Therefore HPV has become primary mode of testing. So this is a very important change that has occurred in this new guideline, and this is the basis why it had occurred. I will not speak too much about basics. Now certain changes. So what if the cell is infested with HPV virus, these are the changes occurs. This is coeliocytosis, hyperkeratosis, and multinucleation. These three things occurs with HPV. Part 2 people had to remember it by heart. For part 3 these changes are not important. And if the cells become dyskaryotic, so these are the changes occurs: increase in nucleus cytoplasmic ratio, mitotic figures, nuclear pleomorphism, and nuclear hyperchromasia. These four like lines about this karyosis cell also has to be remembered by part 2 people, because this is also a part from where your SBA can come. So these are the changes in the cell if the HPV is they're infested with HPV. These are the changes if they are infested. If they're after infestation of HPV, the changes in the cells has come. Okay, so this part you have to learn by heart. Part 2 people, not part 3, because part 3 people, they're not asking this question. Now, it is important to know here why it is important. So this is the normal smear. It appears like this. And this is the mild dyskaryosis, or so the mild changes in the cells are there. And this is the severe dyskaryosis. You can make out changes in the nucleus is like too much increase in the this nucleus, increase in the size, and also it is irregular. So this is the severe dyskaryosis, and here there is an increase in the nuclear cytoplasmic ratio with nuclear hyperchromasia. Why I have put this picture just for visual impression, and also in one of the part 3 exam last year they had given some picture also. So it is important that you have to know how you will identify this picture, because in the picture, in the part 3 picture exam these pictures are also given. So therefore it is important to learn, but but no need to worry. In the part 3 exam usually other clues are also there, so you'll be able to identify, but it was there in one of the exam. Now this again, why it is important to know this. So see, this has been previous terminology. Previously when the cytology reports used to come, so they were with this type of terminology, but now it has changed. Now we are using this terminology. So it is important, because whenever you are giving your viva, or whenever in part 3 or in part 2, whenever you are marking the things, so you have to pick the correct terminology. Okay, so now borderline change will be borderline in squamous cells, borderline in endocervical cells, and and the dyskaryosis they have divided now in two part. Okay, so it is low grade and high grade. High grade is again two types, moderate and severe, but previously these grades were not written. Okay, so if in your question they say low grade dyskaryosis, or they say borderline change with the choliocytosis, your answer will be low grade dyskaryosis, because you have to use new terminology. In part 3 people also, you have to use this terminology in the answer whenever you are doing your viva stations, or whenever you are explaining this to your role player. So terminology has been changed, and this terminology you have to use, though you know already, because the guideline is already giving all the things in this terminology only. Okay, so I'm repeating it again. So it will be borderline change in either squamous or endocervical cell. Low grade dyskaryosis, high grade dyskaryosis will be moderate and severe, and invasive squamous carcinoma, glandular neoplasia of endocervical type, glandular neoplasia non-cervical type. This non-cervical type, like it will include that endometrial CA. So because it is non-cervical, so it will be different. So you have to use this terminology. Right terminology is important for both part 2 and part 3 people to be used, not old one. Now, so this type of report will come when we are sending this for the smear testing. Okay, but you will find what is when the after the smear report, if you have sent this patient to colposcopy and the biopsy has been taken, so after they take biopsy, so there will be histological diagnosis. So histological diagnosis will usually come in this terminology. Okay, sin 1, sin 2 and sin 3, you already know this. uh, this type of description, CIN 1, 2 and 3. And why it is important to understand, this terminology has to be right. So this is smear terminology. and this is uh, terminology when the biopsy has been taken and report has come. So when they see it under microscope section of tissue or histology, so then the scene 1, 2 and 3 will come. So this is histological diagnosis. It is a simple thing, but people make mistake in this also. So because you have to do the right thing. Now for it is important for both 2 and 3 people to understand this, because even the station come from this terminology only. Now you have to understand what is 2 1 2 and 3. So this is CIN1. You can see only lower 1/3 of the cells were involved. CIN2, there are two main like almost 2/3 is involved, and CIN3 complete part has been involved. This picture they are not giving in the exam, but yes, you have to even know this. Also this is the same thing, but part 2 people get question from there. What is the CIN1? It is up to 1/3 of thickness of lining covering cervix has become abnormal. Okay, it is CIN2 is in between 1/3 and 2/3. CIN3 is whole thickness. So usually question comes from here, this line. Okay, they will write in the question your stem basal 1/3. So CIN1, a question come from here. CIN1 is more changes are there in basal 1/3. So remember this basal 1/3. 2 will be basal 2/3, and CIN3 will be entire epithelium. This because you know only one word, as you already know part 2 people, only with the only one word your answer will change. So these definitions usually they come in your question as SBA. So it is important to learn. This is just a visual picture of all, and this is again the same thing, just explaining in this section how the this is normal, this is CIN1 2 and 3. Now this part is important both for part 2 people and part 3 people. How much is the progression to cancer? So like you can remember like this way also, this sort of a mnemonic, CIN 1 2 and 3. So you can just remember this 1 5 12, 1 5 and 12, because this number is usually asked in the exam, that how many portion of sin 1 will or sin 2 or sin 3 they will turn up into cancer. So in if, for part 2 it is important. For part 3, now role player will ask what are my chances. If you are getting reports as sin 3, she may ask you, okay, how many chances of cancer do I have, doctor? How much it can progress? So this number is important for you. Just remember 1 5 12, so the things will be easy. It is important for both of the part 2 and 3 people. And this slide is from strategy. Okay, now a little bit about colposcopy also, it is important, and it is important more for the part 3 people, because in last April the station has come and he wanted to know how to do colposcopy and details of colposcopy, because he was your GP trainee. Because of that I have put some little details of colposcopy here. Okay, so what if, because all these things were asked, will be asked from you if you do like it was a teaching station, so it is important. So if this is a colposcope, you already know. I'm not speaking anything about their lenses magnification, because that is not important for me here today. So what is the important thing that is important from your exam point of view? So what you have to know, so you have to know transformation zone, because this will be asked. It can ask in 2 and 3 both parts. So what is what really happens, the cervical region where columnar epithelium has replaced by new metaplastic epithelium. Okay, so and these are because the metaplastic changes keep on happening, because I already discussed, because of the changes in the pH. So what, so as the activity is already always there in that area, so there will be one zone. So this is the like older zone. So this line, outer line will represent the older squamocolumnar junction, and as the activity is changing, so metaplasia is keep on happening, so there will be formation of a new columnar junction also. So this is new one, and so this is the active area where every activity is happening. So this area that is in between new squamocolumnar junction and old squamocolumnar junction, so this is the transformation zone. It is important to know about this transformation zone, because when the excision will come, so then it will be according to this transformation zone. If the colposcopy is satisfactory or unsatisfactory, or adequate or inadequate, it will be according to this the transformation zone only. So in simple word, yeah, any question? Somebody ask some question? I don't know. Okay, I'm repeating it again. So somebody is asking some question. Any question? Okay. So as always, because of the metaplasia, the activities going on in this area. So there will be old squamocolumnar junction. So this is the old squamocolumnar junction. And then because of the changes or metaplasia, there will be new squamocolumnar junction, and area between new squamocolumnar junction and old squamocolumnar junction is the transformation zone. So it is important to understand this transformation zone, because you have to explain to your role player in part 3, and also part 2 it can come as in definition. So so it is important to know. And somebody has asked, so there is no fixed dimension. Sharvari has asked this question 5 to 7. No, there is no fixed dimension for this transformation zone. Why? Because in some of the people, both of them, if there is no activity, they can coincide also. In some of the people, if the too much of activity is going on, this outer zone may be here also. So there is no fixed criteria, or there is no number, so it is different for different person. So that when you do colposcopy, you usually will be able to find out this transformation zone. And whenever we do colposcopy, we always see this old and new squamocolumnar junction. Those people who are doing colposcopy, they will be knowing this. So how to find out new junction and old junction. Okay, for theory purpose, for your exam, just remember it is an area between new and old squamocolumnar junction. Just remember one line definition. Is the thing clear about it? Is the thing clear? Okay, good. Now this is important. Why it is important? Because it can come in your exam. You may be asked, or in the role player station, you have to explain this to your role player. So there are three types of transformation zone. So type 1, where entire transformation zone, we can see it from our from our eyes. So it is whole visible. Okay, so now see, this is the type 1 transformation zone. Now you see, this is the old one. Okay, this is the old one, and this is the new one, and we are able to see all. So this is fully visible. Now come to type 2 transformation zone. In the type 2, endocervical component is there, and whole transformation zone is visible, but we have to take help. So help is usually taken from endocervical forceps. I don't know those. I have seen this endocervical forceps. It appears like a nasal speculum. So what we have to do when we do colposcopy, we have to put it inside the cervix. So cervical lip will open, and we'll be able to see transformation zone. if this much, because I myself, I do colposcopy regularly, and I have my colposcope also, so I know details of it very well. So if you are using any instrument to open the cervix so that you are able to see complete transformation zone, so it will be type 2. Now this is type 2. You see some part, so this is old scamal columnar junction, and this is new one. So it is, some part of it is inside the cervix or in the endocervix, so you can't see it, if you see it from colposcope, you have to take help of an instrument to open this lips of cervix, then only you will be able to see it. Okay, so this is type 2. Just remember this way, with the type 2, you will be able to see it, but it has got an endocervical component, so you would require an instrument, endocervical forceps, to open it. Now coming to type 3. Type 3 will be completely endocervical. We are not able to see anything. Okay, so this is type 3. Now you can see this is outer squamocolumnar junction, and this is inner squamocolumnar junction, and this is complete TZ and complete TZ inside. Okay, so with any instrument, we are not able to see it. So this is type 3. So it is important for both part 2 and part 3 people, this is important, because role player can ask in part 3 and part 2, people can always get in question with it. Now few things are important. I'll do it very fast, because it was asked in part 3. Therefore I have put all this picture. So usually what happens in colposcopy, so after you have set your colposcope, patient is in a position, so what we do, we apply two types of chemicals. So for number one chemical, what we apply is acetic acid, and strength it varies from 3 to 5%. And when we apply acetic acid, it causes dehydration of the cell temporarily, and also it causes coagulation of protein. Because of that, there will be whitish change. So this is the whitish change. Therefore we call this as an acetowide. Okay, and now you can see that here that it's so faint type of change is there. So because it is not any abnormal thing, it is the acetowide change because of the normal metaplastic physiological activity that takes in the transformation zone. Okay, now I can explain you people. Now you see this line where I'm running my cursor. This is the old squamocolumnar junction. Okay, this is the old, and this will be the new. This is the new. So this area from here and area here, it is whole, this area is the transformation zone. Now with this picture, is the transformation zone thing clear, people?
Yes, Dr. Priyata, yes.
Okay, okay, very good, fine, thank you. So because I just want the thing should be clear to you, so old, new, this is TZ, and this is your acetowide because of the metaplasia. Now if if the cells have dyskaryotic changes, what we just read in dyskaryosis, there is increase in nucleoprotein. Because of the increase in that nuclear protein, there will be increased amount of coagulation of protein. Because of that, there will be so thick whiteness. If so much of thick whiteness is there, so we do have an suspicion, yes, we are dealing with high grade change. Okay, so so this is acetowide appearance of dysplastic epithelium. Just now you can compare it from both of the picture. So here it is metaplastic change, so within a few seconds, it will faint, it will go away. And this is a dysplastic change, and therefore it is so thick. So any of you who is doing colposcopy regularly, they those people, they will see at cervix within a fraction of second they'll be able to see this picture and they will say, okay, this is high grade. So this is like so easy thing, not difficult also. Now you, even from the picture you can make it out. So if this type of epithelium is there in our colposcopy, if I am doing colposcopy, I will not take any biopsy. But this, yes, of course I will take biopsy from this area. Okay, this is just a practical thing. Now again, so one is Acetowide thing I have explained. Now coming to a few things also important you to know. So few terminology is important. When we apply acetic acid, then this tips of, now this is the histological thing. So these are the tips of vessel. So tips of vessel, when we apply acetic acid, they will appear as dots. Okay, they will appear as red dots. And in colposcopic terminology, we call these as a punctations. Now you can see these are the capillaries and these are their dots. They appear as small tips are dots and they appear as punctation. Now you can see here. So you can this is the Acetowide area and you can find so many dots here. This is not an abnormal change. These are punctations. These are tips of small vessels. But these are normal punctation. Punctations are also divided into fine and coarse. So these are fine punctations. These are normal. Coarse may be significant, but I'm not going into details of these punctations now. You have to just know what is punctation for your exam. Now what happens, uh, sometimes, so these are the capillaries. They are not able to reach at this surface. Okay, so because they are not able to reach, so when we apply acetic acid, so what happens, it will give this picture that these are the capillary. They are surrounding some blocks of the cell. So this block type of picture they give on application of acetic acid, and this pattern we call as a mosaic pattern. Like if you see here, so you can see that some blocks are there. So these are the blocks. Actually these are showing this capillary. They are surrounding these cells. So in the on application of acetic acid, top of this basket like arrangement or these capillaries, they surround the cells, and in the medical term or in colposcopy term we call this as mosaic. If it is again it is a fine and coarse. So but I'm not going in any details. You have to just know that terminology. If your role player asks in the exam, you should know this. So what is mosaic? So if the things are clear, and then you'll be able to explain in the exam. Now also after this, what we see the blood vessels, okay, on the cervix. So there are how we can identify it. So usually these are this pattern is called as arborizing pattern, and this is really this is normal. So what does it mean? It means that when this is the main vessel, and whatever will be the branching like a tree, their diameter will go less and less. Okay, so if we take this vessel, all the like small vessels that are arising, there will be lesser in the diameter. It will be like a branching of a tree, and it is a normal arborizing vessel pattern. But if you find like there is no arborizing pattern, some vessels they are thin, some vessels they are getting thicker, then thinner, then thicker. There is no pattern at all. They appears as screw, comma, cock shape. So many things are there. So you have to understand. Okay, you are dealing with an invasive cancer. So this is the vascular pattern, atypical vessels in an invasive cancer, and usually uh, for better demarcation of these vessels, we use the green filter. In the colposcope there is a filter is there, so we will just put the switch on this button of green filter, then this type of appearance will be there. And this green filter is used, it help in more demarcation of these blood vessels. Okay, so just I'm showing you this picture. because if you should know this, because if teaching station of colposcopy comes, so all these few details you have to tell it to your role player. So now what we have learned till now is an acetic acid, changes after acetic acid, vessels, application of green filter. What is the last part of it? Last part of it is we're applying iodine. So we apply Lugol's iodine. So with the Lugol's iodine, this squamous epithelium, so this is a squamous epithelium, it will appear dark brown or mahogany brown, and this columnar epithelium, it will not take changes at all. So this is normal. So so this is normal test, and it is also called the Schiller test. But if in this area, this is squamous cell area, so in this area, if you find any area that has not taken any iodine, in that particular situation, so in that particular situation, you will find that that is the iodine negative area. And if the iodine negative area is there, so that means some dysplastic changes are there, and you will take biopsy from that area. So that will be iodine negative area. But I have put only picture of normal thing, that is the like a normal what will be the normal appearance of the cervix if this Lugal iodine is put. Okay, so this is all about colposcopy. So this much knowledge you should have. uh, and for part 2 and part 3, both people, what type of liquids we are using, why we are using, what will be the interpretation, and how you will do it. So this with this knowledge, you know, there could be a very long thing, but I have to just do the sum up of it only. So now colposcopy interpretation. So what is normal colposcopy finding? So in normal colposcopy finding, when we are able to say squamous epithelium, columnar epithelium, and whole of the transformation zone, then we will say normal colposcopy finding. But in the UK terminology, we will say colposcopy is adequate. Now we will just see some charts in the from this colposcopy guideline. So you will find they will write colposcopy adequate, colposcopy inadequate. So if the colposcopy is adequate, they mean this thing: they are able to see whole of the squamous columnar epithelium and as well as the transformation zone. And if they say it is inadequate, you will find that in a table we'll do now, just now. So if it is unsatisfactory, if we are not able to see any transformation zone, so it will be inadequate or unsatisfactory. These are the just sum up of abnormal colposcopy finding that I have already explained you. So there can be mosaic, punctation, acetowide epithelium, atypical vessels, or iodine negative area. Okay, this is just in sum up, but this is of what could be the colposcopy findings. Now, a few things also you have to know, and this is really important also. So, CIN1. We just read that CIN1. CIN1 is an histological diagnosis. CIN1 usually it has a low malignant potential. It usually resolves spontaneously, and you will always find that these women will usually be smoking, because there is a correlation between smoking and the cervical changes. So we really encourage patient to quit smoking. And for CIN1, usually at first visit, we never treat these patients. We just follow them. But if they are persistent, then in that situation, treatment will be required. So this is all about CIN1. Now you have to know about CIN2 and 3 as well. It has got a higher malignant potential, and standard treatment will be excisional biopsy. You have to take out this the abnormal cells, and you can offer see and treat treatment. See and treat a treatment. What is this? So actually sometimes what happens that when the people are when the people are coming for colposcopy, and at the same sitting we see if there had been abnormal area. So at the same time, if excision is done, so this will be this type of treatment usually offered if the patient is will not be able to come back. So that is it is a kind of a see and treat treatment. Okay, because one time one person asked me what is this see and treat. Now the things might have been cleared. Now there are two type of treatment. I will just do it quickly. So one is ablative treatment and another one is excision treatment. Ablative treatment, that means we are just destroying the cells. So these are the few things: radical electrodiathermy, cold coagulation, cryocautery, and laser. You just have to, you can just know the name of the things for part 2 people. Part 3 it is not that important, but what commonly it is we are using, or it is written in your guideline in the UK, is the cryocautery. So in cryocautery usually it is the freezing of the tissue, and it is performed under local anesthetic. And all this part is important because you have to just explain it to your role player also. And this is again, but you have to know all this also, part 2 people, all the treatments, because it can come in your exam. And this is again from strategy, therefore you have to know this. Just remember this. And the technique that is used for cryocautery is deep freeze. So that double freeze, that will again come in the upcoming slide. These are the excisional treatment. So we already know it is LETS, large loop excision of transformation zone. It is usually done by a diathermy. It is also therefore called loop diathermy. Also, so this is one treatment that is usually done. Another, it could be laser cone, it could be a knife cone biopsy, or towards the end, some of the patient, even hysterectomy is also given as an option. So this part is an important. You should know what is excisional treatment, and this is again from the strategy. So this slide is important because it can again come in your exam. And for part 3 people also, they have to give option to their patient. So you should know this. Now, this is all about basic of colposcopy and also the basic of treatment. Now, I'm just going to this new guideline. Till here, if any one of you have got any question, can ask me before I move ahead. Any question?
Hello.
Yes.
Yeah, ma'am, in case we go ahead with one of these procedures like the laser when you find positive borders, do we repeat the procedure or do we do the comeback slightly? Do we just actually do the follow-up? What do we do if the margins are positive and suppose we did a with third patient, let's say, margins are positive? What do we do?
I'm not able to hear you clearly. I'm not able to hear you clearly.
Hello?
No, no, your voice is not clear. Or you can put in the in this like you can write it so I can answer your question. Someone was asking something, but the voice is not clear. Okay, yes, okay, fine, Anchita. Write your question. Yeah. Okay, so this is the basic that is important for part 2 and part 3 people, and this is the new guideline, Colposcopy guideline 2000. What has it has just updated in February. So now what are the changes are there? It is important to understand. Uh, though it is not too much of changes not there, but they have really made this guideline confusing, So actually they are doing right what new things they have done. So they have as a primary testing in national health services, NHS, they have in cervical screening program. Previously they were using doing smear, but now they're not doing smear. They are doing HPV for all patients. So this is a change that has just come up. So now, so this part is important. So now every primary screening will be with HPV testing. And why they have introduced, why they have put this HPV screening as a primary test? Because it has improved sensitivity and it has got high negative predictive value, and also it decreases the incidence of adenocarcinoma and squamous carcinoma. All the everything is directly from the guideline. So you have to kind of learn this thing, because for part 2 people, they will get an SBA, and so it will come from here. So usually you have to remember at least this line. It has got a high negative predictive value. So because maybe in your SBA this can work as an answer. So this is an update. Now first in this part, few changes are there. So first invitation will come by 24.5 years of age, or when the before 25th birthday, they usually will get letter for the screening. Okay, this is a normal thing. It was same in the previous guideline also. So till 50 they will be called at 5 every 3 years of age, and after 50 they will be called every 5 years. So this, all this part is same. What is the change? So previously they used to call till 65. Now they call it at 60. So last call when they get from for their primary HPV screening, it will be 60 years of age. So this is a change. And why this change is there? Because their next recall will be after 5 years, and after that 5 years their 65 birthday will already have been passed. So this has been changed. Rest this part in the guideline remains same. Now there will be so many
Ma'am, can you
this,
repeat it again, please?
what you want to repeat me?
Ma'am, that it is not up to 65, it is up to 60. After 50 years, it will be two recalls only.
After 50, okay, I'm repeating everything again. So new
Yes.
first invitation, it will be before their first birthday. It will be 24.5 years of age. This you have to remember part 2 people for their SBA. Then till 50 years of age they will be called every 3 years. After 50 they will be called every 5 years. In previous guideline they used to screening used to stop, used to stop at like 65 years of age, but now screening will cease at 60 years of age, because the explanation what has been given in the guideline, that when they, if they call them after 60, so their next invitation will be after 65 years of age. Okay, so by that time there is no activity in transformation zone, so screening is not required. So this has been a change. You just remember in your head that now they will get invitation till 60 years of age. Only till 60 years of age they will get invitation. Is the thing clear?
Hello,
Is the
Yes,
thing?
ma'am.
ma'am, thank you.
Hello, ma'am.
Yes, yes, yes.
Ma'am, means if patient is 61 years,
Yeah.
means if she is means at 60 years she did her HPV testing and it is negative, she won't be called at 65.
No, 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 she won't
Okay,
be.
means last HPV target will be 60 years only.
Yes, yes.
And if it is like she received her 49 or 48, then she will receive after 60.
No, after 50, so after 49 or 50, what you are saying, she will receive a call, but last
No,
call
no,
will
ma'am.
be at,
Sorry, ma'am. 50. I mean to say 58. Suppose she received her last HPV testing at 58 years of age.
yeah,
Then she will receive after 63, around 60. She will receive or not? 58. If
according to
she
this
received her
guideline, 60 is the last. According to this
60 is
guideline,
the
60
last.
is the last. Yes.
Okay, ma'am. This is a change.
Yeah, this
Okay.
is a,
Thank you so much. Thank you,
yeah.
ma'am.
Now in new this thing, uh, new guideline, there had been three confusing tables, so it is too much confusing for me also, but I tried my best so that I can simplify it for you, so hope that works. So this is the table number 1. So this table number 1 is cervical screening protocol. So this is the table. So what, it appears to be a bit clumsy thing, but if you see, this appear to be a little bit easy thing. So I will explain it, then I will go to table again. Okay, so now a patient, just remember, a patient has come for primary HPV testing. The test has come negative. So we are happy. We will just say, okay, go, and you are on the routine call. But situation number 2, HPV test has come positive. Now we have to do something. So what we will do? We will do reflux cytology. So from that sample, now the cytology has to be done, because on the basis of cytology we will just make further arrangement whether this patient should go for colposcopy or we can keep her on follow-up. So now you will do reflex cytology, and cytology has come low grade or cytology has come negative, so you're not worried about it. So in that situation you will say, okay, please come after 12 month time or a year time. After 1 year time we will do again your testing, but anyhow your cytology has come negative, no, sorry, abnormal. In that situation, uh, this patient you have to refer for colposcopy, because now HPV was positive, therefore cytology was done, it has come negative. So this combination, it has become this combination, HPV positive, cytology abnormal. Yes, this is a highly suspicious combination. We will send this patient for colposcopy. Okay, so this happened at the first visit, at the routine, at when the patient comes for primary HPV screening. Now this same patient, we because we said, okay, please come after 12 months time, so she came back to you. Okay, now after 12 months what you will do? You will again do the same thing. So now you will see this thing is same, the exact same of this is there. So after 12 months again you will say, okay, I will do your HPV has come negative. Okay, you will say bye, go to routine call. If the HPV has become positive, again you have to do something, you will do her reflex cytology. If it is negative, then you will call again after 12 weeks time, and if it is cytology is normal, now it again the same combination, HPV positive and cytology abnormal, you have to refer her to colposcopy. Okay, now as you have called her after 12 month time, so she came to you after a 12-month time. Now it is the second time. If you see it from here, so now it is the 24 months have been passed. So here her HPV was positive, and here you called her second time. So now it is 24 months total passed, and there had been a 2 HPV testing for this patient. Now after, on the second time, if HPV becomes negative, we are happy, go back to routine call. But now also after 2 years also, or after 2 HPV testing also, HPV has coming positive. Now if the cytology, so this is a change. Now in this particular situation, if the cytology is negative, if the cytology is inadequate, or if the cytology is abnormal, so any variety of cytology, we are worried, we will refer this patient to colposcopy. Okay, so this is the sum up of this first cervical screening protocol. Now, so is the thing clear, people? If this is the thing clear, with this you will be able to answer
Yes,
your
ma'am.
question.
Yes, it's
Uh,
clear.
Hello, ma'am. Hello,
Yes,
ma'am.
yes.
Yes,
Anji.
ma'am. This HPV positive. If she is positive, then what does this mean? Negative, cytology negative. Okay.
Oh, the
Means
last
after
line, red
2 years, if she is positive, if she is positive after 2 years, then
line. Okay,
even
yeah. Even the
cytology is
cytology is negative.
normal.
We will
Normal
see,
means
yeah, it is normal or it is
then
abnormal.
it means
Yeah,
irrespective of the
irrespective of
cytology,
anything,
ma'am.
we will send her to colposcopy. Yes, but
Yeah,
yeah, you are right.
irrespective of the cytology, we have to refer
Referred her
for
to
after
colposcopy,
2 years.
and yeah, I should have written that word, but I have to use same terminology what is there in that chart, because you know that same words I have to use. Is it
Okay,
clear?
that's clear, ma'am.
Oh,
Clear. Thank you.
hello, Dr. Priyata. I just want
Yes.
to ask one thing is if in the second time HPV is positive, so it means we don't need to do cytology. We have to refer her anyway for colposcopy.
Yes, but
The last
but
line.
according, we have to follow guideline. Cytology has to be done.
So reflex cytology we will do to even if
You will
HPV
do,
is positive for
yes,
that.
yes, you will do reflex cytology, but irrespective of it, what is the report, you will refer her for colposcopy. Is
Okay.
it clear?
Yeah.
Hello, ma'am.
Yes, yes.
Ma'am, is it only HPV first done or both at same time?
What you're saying, repeat again.
Ma'am, if we are doing HPV test, primary HPV test, we are doing that cytology at the same visit itself, or we will call them again and do?
No, we will not call them again. They keep sample. It is not
Oh,
like us. They keep all samples. Okay, is the thing? Have I
okay,
answered your?
ma'am.
Have I answered your
Okay,
question?
okay. Yes, ma'am. In
Ma'am,
SBA, ma'am, in SBA, if it is coming primary HPV testing or another option as primary HPV testing plus cytology, which one we have to choose that, ma'am?
Please ask your question again.
If in SBA they have asked, it's a routine call. How you need to do? The first option is HPV testing. Another
HPV,
option HPV testing plus cytology. Which one you choose?
we will choose HPV.
HPV only, not that cytology.
No, I'm repeating it
HPV with
again.
cytology.
Yes, I will repeat. I'm just explaining it again, because if so, first we do HPV. Okay,
Okay,
if
ma'am.
HPV is negative, then we will say bye to this patient. Please go to your routine call. Now, if the HPV is positive, then only to find out what type of changes this HPV virus has done in those cells, because to know that, we will do her reflex cytology. Is it clear?
Okay, ma'am. Okay, ma'am. Clear, ma'am. Thank you, ma'am. Thank you, ma'am.
Okay, thank you.
ma'am, here abnormal cytology includes both borderline and low grade also, na? Borderline and low grade.
Abnormal is abnormal, everything abnormal.
Okay, ma'am. Thank you.
Okay, and on the other side, you know, I cannot use any other term in this slide, because I have to use same term what they have used it here. Okay, so I'm not using any second, even a single word different. So it is just an easy version of table number 1. Is it clear, people? Now I should go ahead.
Yes, ma'am, please proceed.
Yeah. Okay, now this is table number 2. So table number 2 is colposcopy examination. Now in this colposcopy examination, so what I just explained just in the beginning, colposcopy examination, it will be adequate or it will be inadequate. Normal or abnormal was our terminology, but in UK for normal colposcopy they use the word adequate. So what does it include? Yes, we are very happy because we have seen whole squamous, whole columnar epithelium, and also whole TZ is there. So we are happy. Colposcopy is adequate. Inadequate, we are not able to see transformation zone completely. Okay, so first you have to understand this. Now by this time you all know. Okay, so now this is a table 2, and I will break this table in 3 parts. First I will explain this part of the table. What you will do, if now the patient has come to colposcopy, so in this part we were doing screening. After screening, we have got an indication, we have referred this patient to colposcopy clinic. So in the colposcopy clinic, they will do colposcopic examination. Now if what the things will go, if the colposcopy has become inadequate, so this is the simple way I could make. So if it is inadequate, that means I'm not happy, because I was not able to see TZ. So then I have to decide what should I say to this patient. So I will look at it, her case notes. If I find cytology had been a low grade, then I'm not too much worried about this patient. Low grade, I can say, yeah, you go back after 12 months, you come back to this colposcopy clinic again. I will do it again, and if second time also I am not able to do it properly, then I may consider, yeah, I will remove the transformation zone. uh, so this is one thing, because you can see one time colposcopy inadequate, as her cytology was low grade, I said, okay, please come after a year. After 1 year back also, same thing. In that particular situation, I can even think it is not must I will remove her transformation zone, but I can consider removing of a transformation zone. This is one thing. Second thing, so it is, she's the patient, but I'm not able to see TZ. My colposcopy is inadequate, but if I look at her file, okay, she has a high grade cytology, and also she has got a borderline endocervical. Borderline endocervical is also equally worse. Okay, so in that particular situation, I can't send this patient back for 1 year. No, no, no. Today I will do treatment. So I will do her LEDs today only. Okay. So this is just explanation or sum up of this first part of the your table. So is the thing clear, people, with this slide?
Yes, Dr. Priyata. Yes.
So this is the thing. If I'm not happy with the colposcopy, I'm not able to see TZ. Now,
Dr. Priyata, I did not understand the adequate and inadequate colposcopy.
you joined late.
Yeah, I just because there was no link, I just joined late. Yes, really late.
Actually, I have already explained it, but now I can't go back, but I'll still explain. So colposcopy, actually what we do in colposcopy, we see whole of the squamous column epithelium. We also see whole of the columnar epithelium, and we see transformation zone. So if we are able to see in our colposcopic examination, squamous epithelium, complete columnar epithelium, and complete transformation zone we are able to see, then we are say, yeah, we have done it adequately, and I'm happy with it. So this is adequate colposcopy. But if I'm not able to see TZ or transformation zone completely, then I will say my colposcopy is inadequate. Okay, so this is the meaning of adequate and inadequate. And once I finish the class and recording is off, then I'll go back and I will explain with the pictures again. Okay.
Okay. Thank you. Yes.
Now come to the cervical screening. Now colposcopy has been adequate. So I'm very happy because I have done good thing. I'm able to see squamous epithelium, columnar epithelium, and also I'm able to see my TZ. So I'm very happy because I have done my job well. But these are the recommendations. So I have done colposcopy, but on colposcopy, it appears to me as the normal thing. There had been no impression of CIN, or if any previous biopsy was there, no CIN was there on biopsy, that means it had been a normal biopsy, or there is no biopsy. Okay, so now this is the situation. That means I was very happy because I never found any CIN on colposcopy. Then what I have to do, I have to again see her cytology, because now decision I have to make on the basis of cytology. So if the patient has low grade cytology, so I can refer her to routine call. Why routine call? Because this patient have previously primary HPV was positive. Therefore, this patient was referred to me. But I did colposcopy, and I'm very happy with the colposcopy. There is no problem. So if there is no problem on colposcopy, so this patient can go to routine call. So we can say, okay, so you go to routine call, no need to come back again. Why? Because we are very happy with the colposcopy, and there is no abnormal finding on colposcopy. So what you will say, what to do? Your colposcopy is fine, so go back. Now there can be second type of situation. I am happy with the colposcopy. So when I review her notes, I found she had a high grade cytology. So this patient, now there is a disparity. HPV was positive, colposcopy was adequate, and like I have got no issues with the colposcopy, and cytology is high grade. So this is a disparity. How this can happen that colposcopy is normal and cytology is high grade? So these are two disparate, two things different. It cannot happen. If a patient has a high grade cytology, I should get something on colposcopy also. So I'm not getting anything. So how this is possible? Something we are missing. So what we will do? Okay, let's discuss this on an MDT. Because of this disparity, MDT discussion is important. This is important to understand both part 2 and part 3 people, because only from this line, you will get question. So I'm repeating this line again. Patient has HPV positive. You are doing colposcopy. On colposcopy, you are very happy. You never found anything. Then you saw her notes. Her cytology is high grade. Okay, so there is a disparity. How this is possible? With high grade cytology, I am getting normal colposcopy. No, there is some problem. So I should discuss it. So I will call for MDT discussion. Okay, so this is the scenario where answer will come as an MDT discussion. So MDT team will decide that how what will be the further management plan to this patient. Is the thing clear, people?
Yes, ma'am. Absolutely clear.
Yes,
And
ma'am.
this, yeah, okay. And this I have explained this second column of this picture. This is a second column explanation. Now come in third column, I need not to explain anything, because third column answer will come in table 3. So this is a third column of it. Colposcopy is adequate, but I have got on colposcopy I found no, there had been a high grade change. Okay, something's or abnormal biopsy, something wrong is there. So this patient will require treatment. Okay, so nothing to do here. So what type of treatment follow-up will be done, that is explained in table number 3. So in this, actually nothing to explain. Okay, because this patient requires treatment. Now this is table number 3. This appears to be very scary thing. So, but I will try to break it into simple pieces, so the things will become easy. So now I am in the colposcopy clinic, and I found my patient colposcopy. I have done it adequately, but I'm not happy because this patient has got some abnormal changes. So I have got a suspicion running in my head. Okay, something is wrong. So I have to do something. So what wrong thing can be there? Either it can be SIN1, or on colposcopy impression, I see acetowide, and I have got a suspicion on like it is a low grade lesion. Or second type, I can get high grade lesion. High grade will be more than SIN2 and SIN3 only, or there could be problem with the glands. Okay, So now I will break this table into 3 and I will explain. So if the colposcopy is abnormal, how the things are done. So this is SIN 1 and SIN 2 and CGIN. So first I will explain this part of the table. Okay, so this is the explanation. So this is first part of the table. As I am in the colposcopy clinic and I found that, yeah, this is not normal. There is some abnormality. I find some mild changes there, or if there had been any previous biopsy, on that this previous biopsy, SIN1 was there. So now what is this? This is a treatment for SIN1 only. So SIN1, we just read in the initial part of our class that SIN1 carries a very low grade malignant potential, and only it will turn into cancer in only 1% of the patient. So we are not very keen to treat this patient, but we can't send them back also. So what we will do, we will keep them on some kind of follow-up. Okay, SIN1 usually we are not treating, so we will keep in some kind of follow-up. Now this part you have to learn. So if we are not treating any patient, we will call them, if we are calling them and follow up. So usually without treatment follow up, it will be after 12 months, because anytime we treat CIN 2, 3 or CGIN after treatment, first time we call this patient at 6 months. Okay, so this is a general thing. This will be same everywhere. So now we are not treating this CIN1, but we have to keep eye on her. So we'll say, okay, please come at 12 months time. Okay, so she will come after a year. So after a year, what we will do? We will do the same thing. We have got only one thing to do. We will do our HPV testing. Now, if the HPV testing we have done after 12 months and it has come negative, so we are very happy. We will say, okay, come, go to routine call, but we will call this patient at 36 months. Okay, so after 3 years, we will call this patient. Now, there had been a second type of scenario. HPV has come positive. So whenever HPV will come positive, what we have to do? We have to do reflux cytology, because now we will make decision how to the things to what to do this patient. This will come from cytology report only. Okay, so now we got the cytology has come negative. So if the cytology come negative, now HPV was positive and cytology was negative. So as the HPV is positive, so we can't leave this patient. We have to do something. We will say, please come after 12 months time. Okay, so there will be a call after 12 months. And if it is any time, if this combination is there, blindly you have to send this patient for colposcopy. So in any scenario, HPV positive abnormal cytology, your answer will be referred to colposcopy. Fine. So this time is easy to understand. Now this patient, because you have called her after 12 months, so she again came after 12 months. But this is the second time she is coming. Now in this thing, if she is coming second time, so everything will be same. HPV, if it is coming positive, so you will do cytology. If the cytology is negative, you in that situation you will call this patient as 36 month time, after 3 years. In this and if it is abnormal, of course HPV positive and abnormal cytology will always go to colposcopy. So this part you have to remember, that remember here. So if 2 times HPV has been HPV come positive and cytology is negative both of the time, okay, so second time you can send this patient to routine call. You will not call this patient again after 12 months. So this is a different thing that you have to understand also, that if HPV on 12 months is positive, cytonegative, in 24 months also HPV positive, but cytonegative. So this time you will not do further follow-up. You will send this patient you will call her after 36 months time. So this is this part I'm just explaining. Now HPV positive one time, HPV positive second time. So if the cytology is negative, you have to call this patient on 36 month time or 3 year time. Okay, abnormal cytology we are not worried, because anytime HPV positive cytology abnormal, we have to give only one answer: go to colposcopy. The problem lies if the cytology negative. So if 2-time HPV positive, cytology negative, second time we will send her to routine call. This part is different, and this part you have to learn also. Is the thing clear?
Ma'am, absolutely clear.
Hello, ma'am.
Yes.
Ma'am, can you please repeat the last point again?
Okay, so now I'm repeating. So if our patient has got CIN1, so we can't send this patient home back. We will say, okay, please come after 12 months time. Whenever we are keeping the patient on follow-up without treatment, we always call them after a year. That everybody knows. Okay, after 12 months, what we will do? We will again do HPV. If HPV is negative, we are very happy. We'll just say, okay, go, please come after 3 years. But if after 12 months, so this is for after 12 months, first time she came and HPV has become positive. So HPV positive, you do reflex cytology. Reflex cytology negative. So in that situation, you will say, okay, you have to come after 12 months time. So you will call her once again. But if her cytology becomes abnormal, so blindly HPV positive and cytology negative abnormal, you have to send them for colposcopy. Okay, no, so this is the easy thing to remember. But now this same patient, because her HPV was positive on the first 12-month visit, you call her after again 12 months. So you are doing her HPV test after 24 months. Okay, because you have again called her after 12 months. So but what you will do after in the second visit also, you will again do HPV. If it is positive, then you will again do reflex. If reflex is abnormal, go to colposcopy. But the situation, reflux has come negative. So now the second time reflux comes negative. In that situation, you will not do any other follow up. So you will send this patient to 36-month or 3 yearly call. So what the take home message is, if 2 times on 12-month and on 24-month HPV is positive, cytology is negative, you will send this patient to routine call. You will call her after 36-month time. Now the thing's clear.
Yes, ma'am.
Bushra.
Yes, ma'am.
Yes.
I have a doubt. In case this is screening, so then in that case we'll do a colpo again.
I'm not getting your question.
And
This is
suppose
not,
it is screening and that
we are not, this is not screening thing what we are discussing. What we are
okay, so it's gonna be
discussing,
totally different.
yeah, this is totally different. This is not screening. Patient has
Yeah,
been
ma'am,
screened,
okay,
has been referred to colposcopy. You did colposcopy, you find a CIN1 impression on colposcopy. Therefore, this is the pathway. Now the thing's clear.
Yes, ma'am.
Yeah? Now, this is just to remember, this is UK national screening program. They recommends that 2 surveillance tests at 12-month interval for if they are HPV positive and cytology negative. The same thing I have discussed. They want 2 tests at 12-month interval. So one test will be at 12 month, one test will be at 24 month. Okay, this is the same what I just discussed. Now I'm discussing, so this is the first part of the picture what we discussed. Now I'm coming to second part. This second part is must and very important for part 3, because this is the famous station. So now your patient has come to colposcopy, and in the colposcopy you found, no, it is a high grade lesion. I have got a suspicion, yeah, it could be high grade, it could be SIN2 or more. Then you have to do something. You will do some treatment. And what type of treatment are done for SIN2, that we have already discussed before. So now we have done treatment. After this treatment, So we will send this patient home back, but we have done treatment. Now we have to follow this patient any time. Any treatment of sin sin or CGIN you do, you have to call this patient in 6 months. So this is a famous question for your part 2, part 3, everything. So you have to call this patient at 6 months time. After treatment, please call at 6 months. So what you will do at 6 months, you have got only one thing to do, that is again HPV. So you will do HPV, and HPV test if the HPV test has come negative, you will say, okay, bye, come after 36 months time, or 3 years, after 3 years. And if the test has become positive, so if your cytology, again, irrespective of the cytology result, if it is negative, normal, or abnormal, you have to refer this patient to colposcopy. This is very important to understand. Part 3 station, unless you explain this from here to here, your applied knowledge domain will suffer. Okay, is the thing clear? This is must for everyone to learn. Is it
Ma'am, I
clear?
have a question.
Yes.
Hello.
Yes.
Hanji.
Yes.
Ma'am, so in this, after 6 months recall, like we'll do the HPV first, and depending on the negative and positive, we'll do the cytology, or we'll do the cytology irrespective of the HPV report in the follow-up after 6 months.
No, in this new guideline, always they are doing HPV first. If your HPV is negative, why you will do cytology then? You will say bye bye. Come after 3 years time.
Okay.
You will do
Okay,
cytology
ma'am.
because So if HPV is positive, then you will do a cytology, and as you have treated this patient, so whatever will be the report, whether it is negative, inadequate, abnormal, please refer her to colposcopy. Is the thing clear, any?
Yes, ma'am, clear.
Yeah. And part 3 people, remember this by heart to get full marks in applied knowledge domain. Now this is the same thing. What we have done here, it is the slide, just sum up everything again. So follow up after treatment, so we will call them for after 6 months. For HPV, if it is negative, so we will call them after 36 months or 3 years. If it is positive, then whether whatever will be the, like, if it is positive cytology, if HPV is positive, then if the cytology is not available, inadequate, abnormal, we have to refer this patient to colposcopy. Okay, then if any of this patient has her age has more than 65, then also you will invite, this part is important to understand. From routine call, if everything is going normal, after 60 years, there will be no further invitation for screening. But if there had been any treatment, if there had been any abnormal test, if the patient is on follow-up, then in that situation, you will always call this patient after 65 years also. Because you can't leave, because of age, you can't leave your follow-up in between. Is it clear?
Madam, again.
What you are speaking, what is the question?
Should he stop at the age of 65 if the patient reach 65?
Okay, please understand, if the everything is going normal, patient is on the normal screening, there had been no abnormal smear, there had been no treatment, then uh, uh, she will not be screened after 60 years of age. But as if the patient has got any abnormal thing, okay, any abnormal test, or if the patient has given any treatment and she requires follow up, then if the age is 65 also, then also she will be screened, because now she is not on the normal pathway, she is on the this thing, she is on the treatment pathway. Is that clear?
Yes, ma'am.
So, ma'am,
Clear.
we call after 3 years or 3 months?
If any sample is inadequate or not available, then after 3 months. This is from the old guideline. In old guideline also, if any inadequate sample, for repeat sample, we call them after 3 months time. Okay. Now, all treated patients, I just explained, all treated patients should be followed at 6 months. Why? Because this line is important. You may get an SPA. Risk of cervical cancer in all treated patient, as it was written in the guideline. I found this line important. So there are 2 to 5 times more chances of having cervical cancer than general population. Maybe you can get this as an SBA. How many times the chances of cancer in there in treated patient? It is 2 to 5 times. Just for this thing, I have put this in the slide. Now this thing is also important to remember that yes, if any young girl is coming, the young girl is less than 25 years of age. So if there had been any post-coital bleeding, any post-coital bleeding is there, you have to do PSPV. If you find like any cervical, any other polyp ectropy and cervicitis, anything, you will refer this patient to gynae. But if you have got cervical cancer suspicion, you will send this patient to fast track colposcopy. Why I have this? I have put this chart on the in this presentation, because so this if you have got clinical suspicion of cancer in a patient who is less than 25 years of age, so you have to refer her to fast track colposcopy. So this part is important, because if any SBA comes, therefore I have put it here. Now if any unscheduled bleeding is there, or any unscheduled situation is there, so no additional screening will be done. This was the same in old guideline and also in the new guideline. Whatever will be the screening protocol, it will be according to their pathway. No additional screening will be done. Okay, this is the same thing. Now cessation of screening will when these are the situation when cessation of screening has to be done. If the patient has received radiotherapy to pelvis, in that situation there will be no screening. Why? Because there will be no changes on the transformation zone, and if the cervix is not there, then in that situation also there will be no screening. Okay, so these are the same thing what is written in the guideline. I'm not adding anything because we are doing only guideline discussion. Age, this I have already explained. So routine screening for any individual, so there will be ceasing at 60 years of age. Okay, why? Because their next routine test will be after their 65th birthday. So this is a new thing in the guideline. So age of if the patient is on a normal screening protocol, so age of ceasing HPV testing, it will be 60. This is according to new guideline, new thing. Now if this patient, she has got any abnormal smear, any abnormal treatment, any treatment, and she is on the follow up of that treatment, or follow up because of previous any HPV positive result, in that situation after 65 years also she will be called for follow up, because now she is not on the normal pathway of cervical screening. Now she is on the follow up of the treatment. So this part important to understand. So one of you was asking this question. Now is the thing clear?
Yes, ma'am.
Yeah, okay.
Dr. Priyata, I have one question.
Yes.
Yeah, this slide. Dr. Priyata, in the first line, they say routine screening ends when an individual attends for screening on or after the age of 60. Yani, if somebody is coming for the screening at for example, 58 or 59, then they have to do after their respective, like the before the 65, isn't it? What I I'm getting the point. Do you understand my question? Hello?
Yeah. So, please
Because
repeat your
this
question.
this actually, Dr. Priyata, this sentence, according to this sentence, what they are saying, if somebody is coming at 60 years of age or after 60, then it is the last screening for her. But if somebody, for example, coming at 58 or 59, it means that this will not be last. That I'm getting from this line, because if somebody is coming at 60, so according to the 5 years policy, they have to next will be due after 65th birthday, and according to the schedule, 65 years of age is the cessation of screening. But if somebody is coming for screening at 658, for example,
Yeah.
so she has, it will not be her last. That's I'm getting actually.
Yeah, you what you are saying is right, but according to the guideline, they are new guideline, as they are doing HPV testing, so they are like routine age that they will stop them calling will be like 60. So they have not mentioned what will happen if this patient is getting at 58 or 59 years of age. Will she get again or not? So they have not mentioned it. Okay, they have just said this only.
Ma'am, this is the sentence on the guideline new telling that from the age of 50 and 64, individuals are offered screening every 5 years. So that way, if according to what she is told, even if the patient comes at 58, she will be called again at 63.
Yeah, that's I'm getting actually. It's not like the screening will be end at 60 years of age. It means that if somebody is coming at 60, then they will not get again. But if somebody is coming 58 or 59, they will get it.
Okay, yeah.
Yes,
Because
because
they are
the
keeping the age,
Yeah,
for
because of
screening
that.
till 65.
Yeah, yes, Dr. Sabia, right, because here they are saying at 60 they will stop, because reason being the next visit will be after her 65th birthday. If she is coming at
Yeah.
58,
Yeah,
then next visit will be before 65th birthday, so she will come for
He
the
will come.
next.
He will
Yeah.
come.
I'm making clear because somebody might be thinking that the screening will stop at the age of 60. It is not like that. Screening will stop at 65, the same. But if somebody is coming at 60, then he will
So they
not
will
get the
not.
next screening.
Yeah, yeah. So that means if the patient is coming 59, so she will be called one more time. But if the patient is coming at 60, she will not get any call, because the next call will be after 65th birthday. This
Yeah,
is what
that is the
yes,
point.
ma'am.
Yeah, the point of understanding is that no follow-up should fall after 65th birthday. So if it is there, then we will, it's automatically coming on 60th. That's why they wrote it like that.
yes.
Okay.
Okay, so I was reading it again and again, but that clear picture was not coming. Okay, so now, like for SBA people, if they say like this thing, she has come at smear at 60, so what will be screening at 60? So when she'll be called again, then in that situation, answer will be no. But if they're saying it less than 60, in that situation, like she will get one more call for screening. So this is my understanding. What from this line, and this is I have not changed anything. This is directly same as written in the guideline. Okay, but if any patient who is HPV positive, she is on any follow-up, or if the patient is on any kind of treatment and then she is follow-up, then even after 65 she will be called for screening, because she is not on the normal pathway. She is on after treatment or after any positive test path. Now the thing's clear.
Yes, madam.
Yes, it
Now
is very
clear.
clear.
Yeah. Okay, so this part you already know, same from the previous guideline. Any invasion, any high grade, or any like borderline change in the endocervical cell also. so they will be referred in the 2-week wait pathway. Okay, so and if any low grade borderline change in squamous cell or persistent HPV positive cytology, but cytology is negative, so they will be referred in the 18-week pathway. In last guideline there was a table, okay, that 2 week 6 weeks, 2 weeks, but in this guideline that table is not there. In this guideline only this much they have written. Just you remember this thing only: any invasion, high grade dyskaryosis, moderate and severe, glandular neoplasia, borderline changes in endocervical cell, they are in 2-week pathway. Rest apart from this, it will be on 18-week pathway. But how much weeks they will be referred to colposcopy. New guideline never mentioned anything. Therefore, either they will not ask that question, or if they ask, then answer will come from old guideline only 2016. But in 2020, that table is not there. Now this I put it because maybe it may come as an this they newly they have put in the guideline the faster diagnosis standard. So what is this faster diagnosis standard? So if any patient has been referred for suspected cancer, then in that situation, like within 28 days that diagnosis should be done, whether they have cancer or whether they do not have cancer. So this is the thing that has I read new in this guideline, and it has been introduced, this faster diagnosis standard. They have introduced in April 2020 only. Maybe it may be asked in the exam, therefore I have put this line. So whenever, according to this, whenever any suspicion, any patient suspected for cancer has been referred, so within 28 days he should or she should know whether they have cancer as a diagnosis or whether they do not have cancer as a diagnosis, and the term they are telling this as a faster diagnosis standard. Okay, so it is important if any SBA comes or role pair ask in the exam. Then this part you already know from your old guideline also. So if any so this much they have said about in the new guideline about inadequate result. Anytime if you do HPV testing and if it comes if it is inadequate result, then in that situation you have to repeat HPV after 3 months. It is same in the old guideline also. Anytime you get inadequate sample at 12 months, so we have just seen a CIN1 pathway where we were doing cytology at 12 weeks, we were doing cytology as 24 months also, or second time when we called them also. So if both time we found that their cytology is inadequate, in that particular situation this patient will be require a referral to colposcopy. If any two consecutive HPV are inadequate, or if any two consecutive cytology samples are inadequate, this is basically the same thing. So you have to refer the patient to colposcopy. So this part is important for part 2 people. HPV inadequate, repeat in 3 months time, and if 2 HPV inadequate and 2 cytology inadequate, this patient will require colposcopy referral. Okay, this is not that important for part 3, but part 2 this can come as an SBA. So what you have to do if the HPV or if the cytology is inadequate. Now what they said, if any patient, if you see a patient clinically, the patient is presenting with a postcoital bleeding, persistent vaginal discharge, in that particular situation this patient will be the not suitable candidate for screening. So this patient will require gynae opinion. Okay, so this part is important, for maybe in SBA they will say this, then you have to say refer for the gynae opinion. And if any patient who is referred for colposcopy, and if there had been suspicion that is any suspicion for cervical cancer. This we have discussed before also. This patient, even on the suspicion also, this patient should be put on 2-week wait pathway referral. So this part is not new, this you already know. Then this is written in the new guideline. What they, somebody's mic is on. Okay, so this is what they want in the this they wrote in the new guideline. So in the details of colposcopy examination, they have to what they have to usually write. It is the HPV result. Okay, it is the smear result if it is there. Whether the examination is adequate, whole of the cervix and squamocolumnar junction is visible. Whether any extension to cervix or endocervix extension is there. Any colposcopy lesion is there. Colposcopy impression of lesion grade is there. High grade lesion sin 1 or low grade lesion sin 1 or high grade lesion sin 2 or 3, and what type of transformation zone a patient has, type 1, 2 and 3, or whether any colposcopy directed biopsy has been taken. So these are the just some sum up. So whenever they make an colposcopy report, so all these things they will include in their reports. Okay, now you should by this time also you should know what they mean by the adequate examination. This is not very important, no, but yeah, you should know this. And if you have done colposcopy, so if the your on the colposcopy you found that there is no lesion, or it is a negative colposcopy, the patient has a cytology negative, in that situation you will not do any biopsy. You will send this so it will be less than sin 1. In that situation you will not do any biopsy, you will send this patient back. Okay, so if this is the combination, patient has a HPV positive, you did colposcopy has got no finding, and also cytology was negative, so you will not take any biopsy. Now another type of situation, you did colposcopy, you found that there had been problem in the transformation zone or atypical transformation zone, or also the patient cytology was high grade, so you can't let this patient go, you have to take her biopsy. Okay, so in this situation biopsy has to be taken. Now
Excuse me, ma'am.
yes,
Excuse me, ma'am. Ma'am, what do we mean by atypical transformation zone?
atypical transformation zone, what do you mean? If you are not able to see it, or if you are finding some abnormal colposcopic findings are there. So when we in the beginning of the when we I started the class, in the beginning I explained what are the colposcopy findings. So what are the normal colposcopy finding and what would be the abnormal. If you are finding any abnormal finding, or if you are finding in that particular transformation zone, so that will be atypical thing, that is not normal thing you will find. So again these are
Okay,
the same,
means,
some lesions are there, so you have to take biopsy, you can't send this patient back.
ma'am, it means on colposcopy is positive. It means that
Yes,
colposcopy positive, either suggestive of CIN1 also. Then also we are going on colposcopy. Then also we can take the biopsy.
if you
Means
if the all
atypical.
lesions are the base, if you find some lesion on the colposcopy or you have got suspicion, then you will take biopsy. Without finding,
Yeah,
how why
maybe.
you will do?
Yeah, maybe it means CIN1, CIN2, anything. But even if it is means CIN1 also on colposcopy, then we will take the biopsy.
CIN1 usually biopsy is not taken. We usually put them on follow-up. Biopsy is taken if there is any suspicion, or if it is like more than CIN1. Okay. Any finding is there, abnormal finding, then you will take biopsy. You have got
Ma'am, we
suspicion.
know that high grade cytology usually have abnormal means colposcopy, no, we'll maybe finding
Yes,
something. Then we
yes,
have
you
to take the biopsy, for
yes,
confirmation.
yes.
If suppose patient has not had high grade cytology, she is having just HPV positive, and on colposcopy it is coming, the findings are positive, but it is CIN1 only. She is HPV positive and CIN1 colposcopic features. Then we take biopsy or we will leave that just for
In
follow
that
up.
situation, in that situation, like it will depend upon the finding and upon the person who is doing. So it cannot be fixed thing. But if
Means not because we know that colposcopy 2-3 we have to take biopsy. If it's 2-3 and treat also, see and treat like. If
yeah,
colposcopy
yeah,
showing 2 and 3
2 and 3,
feature CIN, then we have to means see and treat. No, at same
yes,
time we can go for treatment as well, like LEDs and all. But
yes.
if it is CIN1, then means not treatment. We means I'm asking ma'am, means we should take biopsy or not, or just follow it up.
According to this guideline, CIN1 they're not treating.
Okay, ma'am.
Even in our clinics also, we don't treat mild lesion.
Okay, ma'am. We'll just put on follow up for
Yeah,
12 weeks.
yes.
Okay. Thank you.
Now, we have just read what are the ablative treatment possible. Okay. So, what are the indications when we do this ablative treatment? Okay, ablation is just destruction of the abnormal cell. So, these are the situations where ablative treatment can be done. So, you are seeing full transformation zone. Okay. Second, you have got no evidence that any endocervical lesions are there or any glandular involvement are there. You have got no suspicion of invasive disease. There is no history of postcoital bleeding and intermenstrual bleeding. No gland crypt involvement, that is again no gland involvement there on biopsy. There is no history of any previous treatment. No disparity between cytology and histology. So these are the criteria. If these criteria are followed, then ablative treatment can be offered to this patient. And we have read so many types of ablative treatment, but according to this guideline, they are using cryocautery. And this cryocautery, what the technique used is double freeze thaw freeze technique. Okay, so this much, if these are the thing, then only the ablative treatment can be done. Is the thing clear? Is it clear? These are the indications for ablation treatment or ablative treatment.
Yes, ma'am.
Now, when the excision is required, so this is important to know. Now, if you find on ectocervix, there is a high grade abnormality. So in high grade, you have to treat it. So you have to do excision. If low grade colposcopy but high grade dyskaryosis or worse, you have to do excision. Okay. If lesion is going inside endocervical canal, that means this have got a endocervical component also, you have to do excision. And if their cytology is suggestive of invasive disease or any glandular thing, then also excision is required. So these are the situation where only excision will be the treatment. In this situation, no ablation can be used as in treatment. Now these, if your patient comes in this category and there is a you have decided for an excision type of treatment, then this they had given in the guideline. If this patient has got type 1 transformation zone, then your aim should be you will remove less than 10 mm of this like that depth of involvement of tissue will be less than 10 mm if it is type 1 transformation zone. But if the patient has got type 2 transformation zone, then tissue depth of the tissue removed will be 10 to 15 mm. Okay, Okay, so this will be 10 to 15 mm. And if this patient has got type 3 transformation zone, that means it has got a high endocervical component, then the tissue removed depth should be in between 15 to 25 mm. That will depend on the position of the squamocolumnar junction inside the endocervical canal. So these are the dimensions that you have to kind of use, and how much the tissue will be removed if if the excision has been decided as a treatment. So it is more important for part 2, because they can ask you this type of question, how much it has to be how much you have to remove the transformation zone. But for part 3 it is not important, that much important, because you have to just explain, you have to just only explain that what type of this thing, excision will be the treatment. So this much detail for part 3 is not important, but for part 2 you have to remember all these numbers. Is the thing clear? I don't know. Is it clear?
Yes, yes, very clear. Yeah.
Yeah. Yes, ma'am. Absolutely.
Now, this is again thing. So if high grade CIN is there and it is extending to lateral and deep margins of excision, because you have done excision as a treatment. Now, the patient has chosen and the excision was done. When the report comes back, in that situation, it is extending to lateral and deep margins. Then in that particular situation, the like repeat excision is not required. What are the situation when you will not do repeat excision? If there had been no glandular involvement, so we are kind of okay. Or if there is no evidence of invasive disease, if we have a young patient that is under 50 years of age. So these are the three situations. In this particular condition, if the though the CIN after excision, CIN was there and it is extending up to margins, but repeat excision will not be done in this particular situation. This is important for both part 2 and part 3, because in part 3 this type of stations are very common. Hysterectomy has been done, CIN has come, it has been extending to this and this. So what you will do? So you have to know this, because unless you have to kind of decide in your stations what the options you will give to this patient, whether you will say repeat excision or whether you will not say repeat excision. So you have to learn this. Now, if the same patient is there and patient is more than 50 years of age and SIN 3 is there at the lateral and deep margins, in this patient you cannot take risk. This is a over 50 years of age. You have to do repeat excision. You have to get the clear margins. Okay. Now, I'm repeating it again. If the on the tissue report has come back, high grade SIN is there, it is extended to lateral and deep margins. So in that particular situation, if your patient is young, if your patient less than 50 years of age, if there is no evidence any gland involvement or invasive thing, you will not do excision again. But on the other side, if the high grade SIN has come in biopsy, your patient is more than 50 years of age, you can't leave her back. You have to do repeat excision. You have to obtain clear margins. Is the thing clear?
Yes, madam, clear.
Okay, so this thing also, because this is same written in the guideline. If the patient was stage A1, like stage 1 A1, and you have done excision treatment for her, and in this patient if her margins are free of any invasive disease or a sin, in that particular situation, no further excision will be required. If it is only outside, okay, ectocervical region, and again, this specimen has to be reviewed by MDT gynecology cancer. MDT cancer pathologist will review this. So on the other way, how it can be explained, if your patient is of the stage A1A cervical cancer, excision was done as a treatment. If the margins are okay, and if the pathology has been reviewed by a gynae onco MDT, in that particular situation, for this patient, no further excision will be done. Is the thing clear?
Hello, ma'am.
Yes.
Hello, ma'am.
Yes.
Hello.
Yeah, I'm listening. Yes.
Hello.
Yeah, I'm listening. Is my voice clear,
Okay,
people?
ma'am. Yes,
Yeah.
ma'am. It was one is lost actually from my side. Ma'am, it means for stage 1A1, if it is came as a cancer and the margins of that cancer on LEDs is negative, like for CIN in invasive disease, then we need not to do excision for the making the diagnosis, no, ma'am. But the treatment we will do, no, go ahead.
No, re-excision
For
will not be done. Like
for
usually,
diagnostic purpose.
for which diagnosis?
Means cancer means it has came as cancer, no, ma'am. Stage 1A1.
Yeah.
Or it is a therapeutic also. We need not to go ahead for further treatment.
You are saying for cancer staging.
It's both
No, ma'am,
treatment
not
also.
cancer staging, ma'am. This stay means if suppose we did excision for high grade lesion, but the
Yeah.
result came as cancer
Yeah.
stage 1A, CA cervix it came, and it is showing, the report is showing that both the margins of this is clear of the CIN and invasive disease. The margins are clear. So
Yeah.
in that case, we will not do the re-excision for making the diagnosis of means for staging.
No.
But we will go for treatment, no, ma'am.
Okay,
Hysterectomy and all.
See, usually this type of conservative treatment only done for the patient, those who are looking for fertility. If this is
Fertility.
I think is it a treatment also, therapeutic and diagnostic both, no, ma'am?
Yeah, it is both. It is both. It is both. So what they are saying, if you have done excision for any patient,
I
now
think
the
we have to just follow up, huh?
yeah, follow will be there. Follow will be there.
But ma'am, for LEDs actually doesn't come for the treatment of cancer, no, ma'am. LEDs is not sufficient for treatment. Stage 1A1. When we are treating a cancer, cervical cancer, then bone
In
biopsy they have written.
early stages, but they have not said LEDs here. Maybe they have done cone. They are just saying margins. It is not clear, Bushra, here whether they have
Okay.
done lead or whether they have done cone. The only one
Okay.
thing we want to just explain here, we are not discussing
Yeah,
any
ma'am.
cancer here. Okay. So what they want to tell is, if the excision is done in the histopathology, if this has come as staging and you found that margins of that tissue that was removed from the cervix, it has margins were clear, and this again reviewed by MDT pathologist, then in this particular situation, doing re-excision of the margin is not required.
Okay, ma'am.
Okay.
Okay, ma'am. Madam, I want to ask one thing. If the patient want conservative surgery, then for stage 1A1, can we do only therapeutic conization or lesion also?
See, this will depend patient to patient, but yes, conservative or like fertility sparing measures can be done for early stages of cancer. It can be done. Okay.
Okay, ma'am. That means we can do both therapeutic conization and lease also. Any option?
Yes.
Okay,
Yes.
thank you.
But this is up to my knowledge, but I will again post something regarding to this in the group. Okay.
Okay, ma'am.
Okay, now till here, till now we have finished this CIN thing has been finished. So now we are moving to glandular management. That is the third part of that big table 3. Okay, till now any question, or should I move ahead with the glandular abnormalities?
Ma'am, what about re-excision in case of 1A1 stage? Is there any situation where re-excision will be done?
When this criteria is not fulfilled, then re-excision will be done. If the margins are positive, what you will do? Patient wants fertility. So you will discuss the case in MDT and you will give that her as an option.
Okay, ma'am.
Yeah.
Yes, ma'am.
So coming to glandular abnormalities. So this is again, so CGIN. So this is from again strategy. So it is, these numbers are important for part 2 people. So usually it occurs 1 in 200 smear to 2000 smears. I don't know whether it is important to remember or not, but it is your choice. It occurs in older age group as compared to sin. Okay. Colposcopic assessment is required, and usually concomitant sin will be there in 50% of the patient. This line is important for part 2, that sin, concomitant sin can be there in 50%. Please don't forget this number. What is the problem with this gland? Why we are so much of worried? Why? Because they have got multifocal lesions. Usually if it's, we deal with squamous cells, so usually they have got lesions, so we are able to see them. Skip lesions are not there, but in glandular lesions there could be many lesions. So some lesions you'll be see from outside, but there could be some lesions maybe inside, because these glands lie in the endocervix. It has got skip lesions, and also no classical colposcopic appearance is necessary. So important thing to remember for CGN, only this line, like concomitantly it can be present with 50% of sin. Multifocal lesions are there, and also skip lesions are there. Then this part is again, so any borderline change in endocervical cell, this part I have done before also. Any endocervical change, any borderline change even in endocervical is taken seriously, so they will be referred to colposcopy. So this is an indication for colposcopy referral, and it will be done in 2 weeks. So this endocervical even borderline is so important. This neoplasia thing you already know. Glandular neoplasia, cervical or non-cervical, they will be referred to gynae. They will know what the colposcopist will do from here. So any cancer, it will be referred to gynae team. But any borderline change in endocervical cell, it is very important. Within 2 weeks, it has to be seen in the colposcopy clinic. Then this is the same line they wrote in the guideline, like in the endometrial sampling is only indicated if you have got suspicion of glandular neoplasia, not otherwise specified. That means glandular neoplasia suspicion is there, but you don't know from where the cells are coming. So in that particular situation, endometrial biopsy has to be done.
Hello, ma'am.
Then this part, yes.
Hello, ma'am. Ma'am means if it is endocervical cells, till then we are keeping for NHS screening. Means we'll keep the
Yes,
patient in NHS screening. If it is
yes,
not endocervical, any other glandular or anything, then we'll refer for gynae. Is
yeah,
that mean? Okay.
yes. This colposcopy person will do only colposcopy. They will not do
Okay.
anything else. Yeah.
Okay, ma'am. Thank you.
So this thing is important because to know. So in CGIN, treatment is excisional only. Okay. So only one treatment choice. Second, all cases according to this new guideline, they should be discussed in MDT. Treatment is different for young patient and old patient. For young patient means that they desire fertility. In those patients, uh, cylindrical shaped cervical excision biopsy will be taken. That will include whole transformation zone and at least 10 of endocervical tissue above the squamocolumnar junction they have to remove. Okay, this is the young patient. Now if because she wants babies, so you have to be a little conservative. But if she's an old patient, she is 50 years or more, in that situation you have to take cylindrical biopsy, or it will be excision will be in a form of cylindrical biopsy that will include all visible transformation zone and 20 to 25 of endocervical canal has to be removed as an excision. So these two things are important. So because it can come to for part 2 people also, part 3 also, because in part 3 it is station, they can give you that HPV is positive and CGIN has come in cytology. Your patient is a young patient, so what will be the choice of treatment? So this way the station can come. So this is very important, and all these margins, excision, everything you have to remember, and always you have to discuss these cases CGIN in the MDT. Is the thing clear?
Ma'am, this is cylindrical biopsy. That means cone biopsy.
Type of a cone biopsy, but they have to remove inside, so it will be cylindrical in shape. So they want to remove inside endocervix. So when we do cone, we are removing more part of ectocervix.
Yes.
Okay. But here
Yes.
you have to remove inside. So if you have to remove inside, so how cone can remove? It will be like cylindrical only.
Okay. Thank you.
Yeah. Now, so this is
Sorry,
the
ma'am.
treatment.
I have one question, ma'am, please.
Yes.
Ma'am, if like a young patient, and if where squamocolumnar junction is not visible at colposcopy, then we means here there are two indication written, no, ma'am, for taking the tissue cylindrical biopsy of 20 to 25 So if in young patient also, if squamocolumnar junction is not or inadequate colposcopy is there, then we also need to remove this much or not?
Bushra,
Yes,
in
ma'am.
young patient, usually transformation zone is hormonally active. So in
Yes,
young
ma'am.
patient, this type of finding is very less, that you are not able to see transformation zone or squamocolumnar junction. It happens in
Okay.
old patient when it moves inside.
Yes, ma'am.
Okay.
Okay, ma'am. Okay, ma'am.
So
Means it is generally found in menopausal patient,
yes,
inadequate colposcopy.
and just I want to share something, but it is not related to MRCOG. So if sometime, if postmenopausal patient she comes with some problem, and we have to do colposcopy and we have to do transformation zone, so you will not be able to find anything. Sometime even estrogen is given as a treatment to them, so that if transformation zone or squamocolumnar junction, because of this hormones, it will come out, then the colposcopy is done. Okay.
Okay, ma'am. Okay, ma'am.
But
Thank
please,
you.
whatever I spoke right now, it does not belong to your MRCOGs. It is from general practice. Please don't put it in the MRCOG exam. because when I'm teaching about MRCOG, I don't speak anything about current thing or what we do or what is the practice other than UK. Okay, so this is something is not from guidelines, so please don't put it inside. I just wanted to make Bushra the thing clear, therefore I have spoken about that. So now you have got a confirmed case. So this is the cytology. Okay, this was the cytology. Now the case is confirmed for young patient. Again, it is though it is the same thing. It is the excisional treatment. So what can be done? It is the loop conization, or it could be the cold knife conization. Okay, so so this conservative management can only be done if the margins has to be negative, invasion has to be excluded. Okay, so these are the options of treatment for young patient for excisional treatment. Now again this thing, this is very important. Now if the patient has come as incompletely excised CGIN, in that situation you have to do repeat excision, because we are worried about these glands. We are afraid. Why? Because there could be skip lesions, they can turn up into cancer fast. So if in our if we have done we have taken biopsy, in the biopsy they show CGN has been there, but you have not removed it completely, regardless of age, you have to do repeat excision, because your job is to exclude new a negative margin and invasion. If you don't do that, maybe some you may miss some skip lesions or some as it has got a multifocal presentation, maybe you may miss some part of it. Therefore, if the incompletely CGIN is there, you have to do repeat excision. It is must, regardless of age. It is your job to find out that excision has been excluded and margin has been negative. But so this is one part. This is very important for 2 and 3 both people. Now your patient says, no doctor, I will not go for repeat excision, you are doing so many surgeries, I am not ready. Then what you will do? Okay, your patient is adamant, you have to do something. So this you will do. In that situation you will say, okay, if you don't want to go for repeat excision, but we have to keep you for 10 days under our follow-up. So follow-up, again follow-up will be done with the HPV testing. So first HPV, as the treatment has been done, first HPV testing will be done at 6 month time. Second, it will be 12 month after treatment, or it will be at 18 month time, and 9 and annually for 9 years. So this patient, because the excision was incomplete, so you will do complete 10-year follow-up, and this follow-up will be with is like what we do for this abnormal cells in CGN. So this patient will require complete 10-year follow-up, and you can take even help of colposcopy MDT for the guidance. Is the thing clear? You can get this as a question in part 2, or you can get this as in your role player also. They will give a scenario. The patient has come up with an incompletely excised CGN, and you will say, okay, you would require excision, and this role player will say, no doctor, no surgery for me, I will not go for surgery. Then you have to explain this part of the answer to her, then you will get marks in applied knowledge part. Is the thing clear?
Yeah, Dr. Priyata, if it's completely excised, means there is no invasion in the biopsy, so it means we don't need to do follow-up after treatment.
Okay, just wait, that part will come. I will tell you
Okay.
that part. Yeah.
Okay, thank you.
That chart has not come, what I have to say. We will do follow-up. There will be testing at 6 months. There will be testing at 18 months. And if both tests becomes HPV negative, then she will go to routine call. I was just about to tell that. Yeah.
Okay, thank you, sir. Thank you.
Is this thing clear, people? Should I go ahead?
Yes, madam. Excellent.
Okay, so I think this was that Saishta was asking. So if you have done your job very well, margins are clear, but you have to keep this patient on under follow-up. Now, we have done treatment. After every treatment, we will see our patient at 6 month time. So we will call her at 6 months. We will do HPV testing, and now we will call her again at 12 month time, or you can say 12-month time from this testing, or 18-month time from treatment. So we will again do test. If both of these tests, HPV testing, has come as negative, then in that particular situation, this patient we will call at 3 years time for further testing, and we can put this patient on the 3 hourly routine call. This is the question I think Sashta was asking. Have I answered your question?
Yeah. Thank you.
Yeah. And anytime in your follow-up, if HPV is positive, your answer will be same. Now, by this time, everyone knows HPV positive reflex cytology. According to cytology, colposcopy referral. So this part is like same. Now I will I would like to explain this also. Now, this is the same situation here. You have done treatment for CGIN. You call your patient at 6 month time. Okay, but she was a busy person. She didn't turn up. Okay, then she turn up at for second TOC. Okay, so if the second TOC comes normal, then also this patient will be put in the routine call. So this is the same scenario, but this call patient didn't come in your hospital, in your clinic. So first TOC was not done. She came during the time of second TOC, but that time it is normal. Then also you can put this patient on the routine call. It is the explanation of same. Now this part again, if any HPV testing has come positive or abnormal cytology is there, then this patient will require colposcopy referral. And if the colposcopy referral also, but any cytology negative, it is CGI patient, any cytology negative, abnormal, in that situation, you have to do 10-year follow-up. But this 10-year follow-up, in previous guideline it was with smear, but in this new guideline HPV has become the prime thing, so 10-year annual follow-up with HPV testing will be required. Okay, now whatever we have discussed, this is the sum up. So this is the last part of this thing, that chart number 3. So this is the chart number 3. This is the last part, glandular treatment, CGIN. So whatever we have discussed till now about glandular treatment, this will be the sum up. This table will do the sum up of everything again. So if you can remember this, then all part is done. So you treated a CGIN patient. Any treatment patient, please call her after 6 months. Patient has come, so you do HPV testing. HPV testing you will do at 6 months. Then if it comes negative also, then you will call this patient after 12 months, or you can say 18 months after treatment. If both of this HPV becomes negative, then patient will be on routine call. You will call this patient at 3 years time. Okay, so in C, now you see this pathway, this way. So if the CGN is there, you did treatment, you called her at 6 months, HPV negative, we are very happy. We called her again after 12 months, second HPV also negative. Patient, no, we are very happy. HPV at 6 months, HPV at 18 months. That is 12 months after treatment also, 12 months after first TOC is also negative. So we got 2 HPV negative. We are very happy. Okay, our burden is less. This patient will be called at the 36 month time. Okay, so this is this part of the explanation. This is quite easy also. So if you're in your station, if the CGIN is coming as a role player station, you have to say, okay, we will we have to do 2 testing. One will be done at 6 months, one will be done at 18 months after treatment. If both comes negative, then only you will be able to go for routine call. So this part is different from sin treatment. So please remember this, because this part you may make mistake in the exam, so it is important. So now we are negative pathway, this pathway we have done. Now come to positive thing. So this is the positive thing. So if the HPV becomes positive, okay, and okay, whether the cytology is inadequate, or if the cytology negative also, then in that particular situation we will refer this patient to colposcopy. Okay, so the patient will be referred to colposcopy. If the colposcopy normal also, then you will call this patient again after 12 months time. In the 12 months time, it is the same pathway. So in that particular pathway, if the cytology is negative or inadequate, you will refer this patient to colposcopy. If the colposcopy is normal, you will call them at 12-month time. So this will be the pathway if the cytology is negative or inadequate. Okay, but in this particular situation, anytime if the HPV is positive and cytology is abnormal, any abnormal cytology you see in CGIN with HPV positive, please ask for 10-year complete follow-up. So these things are different in this glandular treatment. Is the thing clear? This is the last part of that third chart. Is it clear?
Yeah,
Any
clear.
question? Now this I have just copy pasted from this new guideline also only. So stratified mucin producing intraepithelial lesion of the cervix. Okay, so they are putting a small word as smile, and what they said, if cytology, like it is a histological identity that is usually found in conjunction with CIN or CGN. But the tree, if in your histology picture has come and they have written a smile, that is mucin producing intraepithelial lesion of cervix, the treatment line, it will be same as CIN or CGIN. So the take home message, if you find any smile thing again with CIN or CGIN, your treatment path will not change. Your treatment path, your everything will be same what we have discussed. So if any time you see this smile, so just see if the CIN is there, you do station or treat part 2 according to CIN pathway. If it is smile plus CGN, so you have to do according to CGN. It could be there along with this. So this is newly they have added in the guideline, therefore I have put it here. Is the thing clear about smile? This is new thing, you know. Now what are the indications of hysterectomy after CGIN? Okay, so now this patient is in if your patient is in does not require any baby, why to keep this thing inside? So in that situation, this cervix inside, so fertility is not desired, this patient can go for hysterectomy. If you have done her cone by cylindrical biopsy, or you have done any excision, margins has come positive, in that situation also you can give this patient as an option of hysterectomy. If your patient does not want to go for any excision or conservative treatment, it is an indication for hysterectomy. If she says no, I will not come for 10-year follow-up, you know, in that situation also an indication for hysterectomy. And if if the patient says that invasive disease has been confidently excluded, because if the invasion is there, so you will treat this patient treatment will be done, and this will be done according to the cancer pathway. Okay, so in that situation you can't only do hysterectomy. So if the invasion disease has been confidently excluded out, so you can offer this patient as an hysterectomy. So these are the indication of hysterectomy. If your diagnosis of your patient is CGIN, so in this situation hysterectomy can be done. It is important for part 2 people because they can get this as an SBA, or but it is also important for part 3 also, because if you get old role player or old age role player and CGN has come as an diagnosis of the this biopsy, so in that particular situation, apart from excision, you can also offer hysterectomy as an option. So this knowledge is important for both 2 and 3 people. Is the thing clear? Should I move ahead? Okay, so okay, again, if the like stage 1 A1, what we just discussing just now, if we have done conservative management, in that situation, this patient has to do this thing. Primary 6 months, there will be, we have to follow this patient. How would be the follow up? So it will be 6-month follow up, 18 months follow up, and annual next 9 years. So if you are doing conservative management for stage 1A1, in that particular situation, this patient will be on 10-year follow up. Okay, unless the complete treatment has been done. This part has been newly added in this guideline. Is the thing clear?
Madam, this is just like CGIN treatment,
Yes.
after
Yes.
CGIN treatment?
Yes. Same.
Okay.
Same.
Madam, I want to know one thing. If HPV positive in first test of cure and cytology inadequate, and second time HPV positive and again cytology inadequate, then we have to complete total 10 years follow-up?
In this, if you are following this pathway of cancer, so you have to keep this patient for follow-up for 10 years.
Okay.
Because cancer was primary thing and conservative management has been done. You already know cancer can come back anytime. So you have to keep this for this patient for 10-year follow-up. And anyhow, if in your follow-up her disease is progressing, then at that time you will take another decision. Is the thing clear?
Yes, ma'am. But I want to know, sir, for CGIN, if first test of cure HPV positive but cytology inadequate, and second test of cure HPV positive but cytology inadequate, then we have to refer the patient for colposcopy. If colposcopy normal, then routine, then recall in 12 months. I cannot understand this recall in 12 months. That means whether we have to follow up for total 10 years or not.
Okay, so this part, okay, so actually for this they have not said anything when this patient will go to routine call. They have not
Yes,
mentioned
ma'am.
any. Yeah, I got it, but they have not mentioned anything of this. So if the cytology is inadequate, so this patient will be referred to colposcopy. If it is normal also, then it will be colposcopy. Then again you will call it a 12-month time. Okay, if it is negative, then she can go to recall. Here if it is negative, she can go to recall, but if here again it is positive, so okay, so in that particular situation, anytime if she is negative, okay, so she will come here.
Okay.
And yeah, anytime.
Yes.
Again, when you will call this patient after 12 months, if this cytology is inadequate, then you because the HPV was positive, so you will send this patient to colposcopy. Maybe because cytology was already inadequate or negative, there is very high possibility of getting normal colposcopy. If then the colposcopy is normal, then you will call them after 12 months. In that 12 month, if again you will do HPV, if that HPV becomes positive, then she will go on same pathway. But if the HPV will become negative, like this pathway, see the here, so if the HPV becomes negative,
yes,
then she will go to routine call.
Yes, ma'am.
Here
But
she will
if
go to routine call.
yes, but
Okay,
ma'am,
see,
if SPP positive, just following the pathway, SPP positive and again cytology negative
again
or
cytology,
inadequate, and
then again 12 months. So this process, like, see, what they say that HPV usually it takes up to 2 year time to become negative. So here, if it is coming positive, and here and the colposcopy is and the cytology is negative, if the cytology is negative, so you can suspect that you will get normal colposcopy. If the colposcopy is normal, you are not sending this patient back. You will again see her after 12 months time. In 12 months time, if the HPV is positive, so this pathway will remain same. So unless her HPV becomes positive, you will be calling her, and once her HPV becomes negative here, then when the 2 HPV will be negative, then she will be put on the recall 36 month.
okay, that means if second test of cure HPV positive, then recall in 12 months, and in this way annually we have to follow up this patient.
Yes,
If negative,
unless she is negative, unless, so they have not given any number here, but unless your HPV becomes negative, you have to follow this patient. So there will be call, you will recall her in 12 months time. But as they have given a clear cut number here in this pathway, they have given clear number 2 HPV negative 36 month. Here they have given clear number 10-year follow up. For this pathway they have not given clear number, but
yes ma'am, yes,
yeah, number is not there, number
yes,
they have not
but
given any
we have
number.
to follow up annually.
Yeah. We have to follow up
Yes,
unless HPV becomes negative, but the number has not been given. So I
yes,
cannot put anything from my head also. So we have to just follow the same whatever they have given. But in the exam, you get question from this pathway and this pathway. They never ask you this. Okay. So
okay ma'am, thank you so much.
you have to know this, but you have to learn this. Okay.
Yes ma'am.
Excuse me, ma'am.
Yes.
Ma'am, do we have to follow these new guidelines, or we have to read in addition with the old guidelines also, ma'am, for exam?
Difficult question. Few things from the old guideline you have to read. For example, that table of referral, 6 weeks,
Okay, ma'am.
2 weeks. In my opinion, you have to read that, because if it comes in a part, if you are a part 2 people, you have to read that. Okay,
Okay, ma'am.
because if the SBA comes from there, you have to answer. Again, in old guideline, infection part was there. What will be there if actinomycosis there, candida there, bacterial vaginosis is there. So that part of infection you have to still read from old guideline, because they have not mentioned single word in new guideline. So in my opinion,
Okay, ma'am.
please, those two things you have to read from old guideline. Rest
Okay.
everything has been changed. Yeah.
Thank you.
Ma'am, this the one which you told previously, sin one, the previous slide, ma'am. Ma'am.
Which
In
one?
this now ma'am, this slide itself, it says that the guideline, new guideline says that for stage 1A1, first test will be 6 months after treatment, second test will be 12 months after treatment, and then annually. This is different from CGIN, where the first test will be at 6 months and second will be at 12 months after treatment. So this is not 18 months, it should be 12 months, ma'am.
No, because I'll make you understand. So if they say 12 months, so they count it from first TOC. If they say 18 months, they count it from treatment.
No, ma'am, the sentence exactly tells a test of choice for stage 1A1 should be taken 6 and 12 months after treatment, then followed up annually for the next 9 months. This is for stage 1A1. In case of CGIN, it is going to be 6 and 18 months after treatment.
So
So this
what you
particular
want?
sentence specifically is there.
So what?
So it is
So what?
6 months and 12 months after treatment for stage 1A1. This 6 and 18 months is for CGIN.
Okay, yeah, yeah, you are right. So now is the things
Yes,
has
ma'am.
become right. Yeah, okay, yeah,
Yeah, ma'am.
yeah,
Now it's fine.
yeah. Yeah, it is like that. Only for cancer, we always do after 6 months, then yearly. So it will be a year. It cannot be 18 months. Yeah, you are right. Thanks for correction.
Thank you, ma'am.
Yeah, it is always like that only. First test will be 6 months, then it will be yearly. So yearly will be 12 months only. So while I'm making, I wrote it wrong. Okay, so this is the follow up if the conservative treatment for stage 1A1 has been done. Okay, so this you have to remember, important for part 2 and part 3 people, because if the role player comes and you have done conservative treatment in this part of the cancer, so you have to explain her 10-year follow up. So part 3 people should learn this. Again, so this has been added new in this guideline. It was not there previously. Okay, again this part also had been added new. So if the stage of the cancer is 1A2 and 1B1, and usually in this stage, if the patient desires fertility, trachelectomy is done as a treatment. Okay, if the trachelectomy has been done as in treatment, this patient will be put on follow-up, but that will be decided by oncologist. Okay, and if the hysterectomy has been done, then a follow-up will be decided by cancer guideline. So if the radiotherapy is given, this patient will cease from any kind of screening. This is again, it was I think it was not there in previous guideline, but you need not to remember anything here. So if the trachelectomy has been done, oncosurgeon will know. If the hysterectomy has been done, or like in that situation, patient will be in the cancer pathway. So the cancer people will decide how the things will be taken forward. Basically, oncologist will decide. Radiotherapy, we have done it previously also. If any time radiotherapy has been given, no screening can be done. So you have to kind of, for your part 2 exam, it is important you may get an SBA from here. Okay, this part is important, and there is a change here. Now, if please understand it very well. Now, your patient, you will get, this is for 2 and 3, very important. So if you have got, if the hysterectomy has been done, but there had been no problem in the hysterectomy, no CIN you found in the hysterectomy sample, so you just forget it, you have to do nothing. But if you found CIN and you have done complete excision, in that situation you will test H at 6 months. This is a change from old guideline. In old guideline, completely excised sin, the test was done 6 months and 18 month time. So there is a change here. Here in this particular situation, uh, completely excising, only you have to do one test at 6 month time. This has been a change. Now, if negative, now in this particular, and they do vault sample, and vault also, they are doing HPV. So if the negative, then there is no issue. But if this patient HPV comes positive, then you are worried. Why you are worried? Because there could be possibility of vaginal lesion. Hysterectomy has been done, sin has been completely excised, HPV is positive, so this patient would require referral, because there could be possibility of VAIN or vaginal disease can be there, and if your colposcopy becomes normal, then you can discharge this patient. Is the thing clear? After hysterectomy,
Please repeat.
after hysterectomy, if the sample, there is no problem, no CIN in the sample, so you will not do anything. But if a patient had a sin, but it has been completely excised, then you will do one test. You will call this patient at 6 months. At 6 months, you will take wart sample, and if the wart sample it will come negative, then you are happy. Okay, no problem. You go home. But if you took wart sample and it comes positive, in that situation there will be concern in your head. Okay, there could be possibility of vaginal lesion because cervix has been removed. What is left is vagina. So you will refer this patient for colposcopy. If the colposcopy comes normal, then you can discharge this patient. This is it clear? The things have been
Ma'am, I have
stated.
a question.
Yes.
Ma'am, this test is only HPV or is it HPV? Like previously we used to do test of cure, no? Which had cytology and the HPV. This is only HPV in this
It is
test?
HPV. They have not clearly mentioned it in the guideline, but according to what I was reading, it was HPV. Therefore, only one test. Okay, because it has got high sensitivity.
Okay, ma'am. Thank you.
Okay, now this is the thing when it was completely excised. Now it is incompletely excised. So now this part is no need to remember because this is ditto same from previous guideline. If incompletely excised sin 1, so walt sample you have to do 6, 12 and 24 months. But if it is 2 and 3, okay, if it is 2 and 3, then again same pathway, it will be 10 years. It will be 10 years pathway. 6 month, 12 month, 9 annual walt samples has to be done. This has not changed. This was same in the previous guideline also. Okay, there is no change here. Now now the glandular thing has been okay. Now I'm moving towards colposcopy and pregnancy. So
Ma'am, I have a question here. Will the
yeah,
follow-up be till 65 years?
in this patient,
Yes.
okay, either so what they say, it will be continuous till
Or until
65
10 years.
or
Yes,
until
yes.
10 years after surgery. So 10
Yes,
years
yes.
will be
Thank you.
there. Yeah.
Yes, yes, ma'am. Thank you.
Okay. So colposcopy and pregnancy. So in colposcopy and pregnancy, what they say, if you have to do colposcopy in pregnancy, either it can be done in late first trimester or early second trimester. So this part you already know, and like it comes in SBA also. And what are the indication of colposcopy in pregnancy? If there had been any abnormal previous screening or any abnormal previous colposcopy is there and this patient was on the follow-up, in that particular situation you have to do colposcopy in pregnancy. Now if your patient is pregnant and it is a routine call for her, then no need. This patient can defer her call. Defer her call, that means she can go for screening once the baby is there. No need to go for routine screening if the patient is pregnant. If the patient is pregnant, this is same from the old guideline. Has been no change. Again, if there had been like a patient was on follow up and there for CIN1, then in that particular situation also her assessment can be delayed after delivery. This was also same from the previous guideline. There had been no change here because less than sin like sin 1 is a low grade lesion. If she was any kind of follow up, if you delay it after delivery, there will be no issue. This is same from previous guideline. Now what they say, this is the same they wrote in the pregnancy. In the pregnancy, if they have to do any kind of invasion, what is the rule, what is the aim? Their aim to rule out any kind of invasive disease is there or not. Okay, so and if any kind of excision is done, so it will be done in the like because the risk of bleeding or hemorrhage is there, so it will be done for the people who have got high grade disease, concern about cancer is there, and it will be done by expertise only if the facilities are there. But you have to remember only one thing here. So if any kind of excision is done for diagnostic reason in pregnancy, you will only do if you have got any suspicion for invasion. Okay, so this part again it is the same. So if the CAN1 is there, so this patient it will be on the normal pathway, and any screening can be done after the delivery. But if it is CN2 and 3, in that situation you have to do colposcopy. So you can do it in that situation. Follow-up thing you can do at like at the end of second trimester. But if your patient is already past that age, she is only already 30 weeks, then in that situation you can wait till she delivers. In that situation her screening can be done 3 months after delivery, once all the changes of pregnancy has revert back. Okay, so this is same from the previous guideline, there had been no change. And any kind of invasion or cancer, it is required treatment even the pregnancy also. But the risk of hemorrhage is there, that we already know. So appropriate facility has to be there. So in pregnancy and CAN, it is almost the same what was there in the previous guideline. So is the thing clear? Now, a few things. If the patient is on contraception, like for example, patient was on OCP and she's on cervical screening. If any test it comes abnormal, that particular situation, no need to change any kind of contraception. So whatever the contraception she's using, if she is using any kind of pill, she can continue with this. If patient has intrauterine device inside and any cervical screening test comes negative, in that particular situation also there is no need to remove IUS routinely. Okay, so and if this patient wants to go ahead with this removal, in that particular situation you have to give advice about other methods of contraception. So the take home message is that there is no change to do any change in the current method of contraception if any cervical screening test has become abnormal. So there is no change. Second, this part is also important, that is new in this guideline only. If there had been, what the guideline says, if the consistent use of condom is done for 3 months, it helps in HPV clearance and also SIN1 regression. So this has been new line, I found good in the guideline. So this part you have to know because it can come in your question also. Okay, so this is all about contraception and cervical screening. Now, if your patient is on HRT, there is no change. The protocol will remain same. Okay, we will not do any change. If your patient has come with a postmenopausal bleeding, in that situation so you need not you will think whether I should do any cervical sample. Actually cervical sample will not be adequate for postmenopausal bleeding. You have to do PS, you have to do direct visualization of cervix, and you have to do gynae referral. This part everybody knows also, but as it was there mentioned in the guideline, so I put it here. But anything on a HRT, no change in the screening schedule. Now this is also important, it comes in the exam, it is important for about 2 and 3 people. If any patient is going for hysterectomy, so as a pre-op investigation, like we check hemoglobin, like we check all other investigation, we have to see her cervical sample also. So cervical sample is a part of a pre-op investigation. So you have to check her cervical sample first, then only you can if the cervical screening is normal, then the hysterectomy, she can go for hysterectomy. This part 2 and part 3, everyone for this to know is very important. And if any previous cervical smear result is abnormal, in that situation you have to first arrange for diagnostic colposcopy biopsy. You have to make a diagnosis. If all the cervical thing has become normal, then only she can go for hysterectomy. Is it clear?
Ma'am, is it
Yes.
HPV also or just cervical smear? Hello, ma'am.
Yeah, so they have wrote cervical sample, so that means like this HPV has been added newly, like recently it has been updated. But if this patient, she's a part of new screening guideline, like a new screening protocol, if she has a HPV testing, so it has to be negative. But if like she is right now not on any new pathway, if any previous result is also there, then you have to make it sure that whether it is a new HPV smear, HPV screening result, or it is old smear result, but it has to be normal before she go ahead with the hysterectomy.
Or
Okay.
shall it be HPV and then reflex cytology? No, only cervical sample.
Yeah, they wrote the same wordings, cervical sample, because HPV and smear both are cervical sample. Both are cervical
Okay.
sample, because in
Ma'am,
February this guideline has come. So everything cannot be changed suddenly. So some patients will come for hysterectomy, they will come with smear report. Okay. Yes, someone was asking some question.
So it
ma'am,
means they are following the routine follow-up. If they are not following routine follow, we will do before the hysterectomy fresh sample. If they are in routine
Yes,
follow-up,
yes, yes.
then we just follow the report.
Yeah, basically, Shaishta, you have to check the cervical sample. As we
Yeah,
check for
is it normal or
hemoglobin,
no?
yeah,
Yeah.
it has to be normal before she go ahead for hysterectomy. If any
Okay.
problem is there, so you have to arrange for her smear, colposcopy or biopsy
Colposcopy.
first. Then she can
Yeah.
go for hysterectomy. Otherwise, she cannot go. So like in our countries, we are not bothered about it. But in their
Yeah.
country,
Yeah. Okay.
is the thing
ma'am,
clear?
if cervical screening 2 years ago and that was normal, then after 2 years of previous normal screening, the patient is undergoing hysterectomy, then should he have to do again cervical
No, no,
sample?
no, 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 no. You will not do anything again. You have to just
Okay,
check it. You have to just check it.
okay, ma'am. Thank you.
Yeah, yeah.
Make the sense.
Okay, when any time for cervical reason, if the hysterectomy, why you do hysterectomy for cervical reason? Like previously, what I explained you is for CGIN. But when the hysterectomy can be done for cervical reason, when you have got histologically proven sin, whether or endocervical cytology, like despite excision, it becomes positive. So in that particular situation, she is going for hysterectomy. If there are these are the reasons she is going for hysterectomy. In this particular situation, what they are saying, that there could be possibility of vaginal lesions. So vaginal mapping can be done by a colposcopy and iodine before she go for surgery, because during that time, if the surgery is done and you find vaginal lesion, so surgery for vaginal lesion can also be done. Okay, so now if you are doing hysterectomy for any cervical lesion, okay, in this particular size, if situation, if you have got any suspicion, then at the time of surgery, vaginal mapping or can be done with the iodine, because if any VAN lesion is there, so at the same time, you that can be also taken care of, because it being a multifocal disease. Okay. Now, these are the now last part of the guideline. If the patient is on renal failure, if patient has renal failure, or patient is on dialysis, in that particular situation, patient should have a screening sample at the diagnosis when the of renal failure, or it will be shortly after diagnosis. Okay, if this patient is not up to date with the screening, so you can get a question, this patient was not following screening schedule, now patient has a renal failure, she has come on dialysis, then you have to answer would be you have to arrange for cervical like screening sample at the diagnosis, or even it can be done shortly after it. So it is important. Then if any patient have got abnormal result, again they have to refer for colposcopy. So this they wrote about dialysis thing in the guideline. For transplantation thing, what they wrote, any patient who is going for transplantation, they should have at least cervical smear in previous year. Okay, cervical sample has been done in previous year. That means, like one of you were asking, if she has like sample 3 years before, so what we do? So I said the answer, no, you have to see just the sample. Okay, but it is the not this that was the scenario in case of hysterectomy, but it is not the case for transplantation. If a patient is going for transplantation, she should have cervical smear in previous year. So for example, at this in this year she is going, so if we have to check her smear cervical sample, if it is done in last year, then we can send her, but if it is not done, then we have to do her cervical sample. This is for the transplantation they wrote. Again, what they wrote in the guideline, if any patient is on immunosuppression drugs, so you know this HPV, it all this CIN and all these lesion HPV progression is more if the immunosuppression is there. So any patient who is in immunosuppression, they should be engaged in cervical screening. For example, they should not miss any cervical screening. So this much they wrote about dialysis, transplantation, and immunosuppression. Then this thing also they put in the guideline, if the patient has got multifocal disease, for example, they have got any cervical disease, or because HPV causes multifocal disease, involvement of like apart from cervix, vagina can be involved, vulva can be involved, or so what they said, if the patient has multifocal disease and patient is on immunosuppression, in that situation every 6 months this patient should be reviewed. So there will be system inquiry, there will be cervical screening, there will be colposcopy, vulvoscopy, and biopsy if it is indicated. Okay, so this is the management if your patient has got multifocal disease. It is directly copy pasted from guideline, nothing I have added from my side. So you can get this as an SBA, so you should know this.
So does it include HIV also?
No, you have to wait for HIV. Just wait,
Oh.
that is coming. Now, no additional screening is required if the patient is taking any cytotoxic chemotherapy. Okay, if the patient is taking tamoxifen, no additional screening. This biological drugs, if the patient is on, no additional screening. If the patient is taking cytotoxic drug for rheumatology, no additional screening. This part you have to remember, because sometimes you may get this question, the patient is on tamoxifen, or the patient is on chemotherapy, when the screening should be done, so your answer will be no, she does not require any additional screening. This part has been newly added in the guideline, so I have, because I'm doing whole guideline, so I have to put this also. So what they say, if the individuals like those who are exposed to diethylstilbestrol, this type of patient, like they have got, if the girl is born, if the mom is taking this and the girl is born, so there is a high risk of clear cell carcinoma of cervix and vagina. So what the guideline says, like they should be put for routine call and recall is appropriate. So that much is okay for them. But again, local arrangements can be done for follow up. So it can be done by annual colposcopy. So like it is a local arrangement, but it is not the recommendation for the guideline. So I have put it here because they wrote in the guidelines, so I have to bring into your notice. But according to the guideline, routine call and recall is appropriate. So, on the other side, this thing is important. You can get an SBA. So granddaughters of those who exposed in for DES, they are not at risk of any cervical and vaginal cancer. This part has been newly put in the guidelines, so I made it here. Maybe you can get question from this line about the granddaughter as SBA. So your answer will be the granddaughters of the person who are exposed to DS, they are not at a risk of any vaginal or cervical cancer. This much is there in the guideline about DES. Now this is the if your patient is HPV positive, then in that particular situation there will be initial colposcopy and annual screening. So this is the guide, this is the line they wrote: initial colposcopy and annual screening, and subsequent colposcopy, if it is required or not, that will depend on the screening thing. Okay, if it is less than sin 2, then no treatment will be done. If it is higher grade lesion on HPV positive, HIV positive patient, then the treatment will be what we discuss according to national guideline. Criteria for ceasing for cervical screening at 65 of age, or like it will be like any other general criteria. So when the cervical screening will be ceased for them. So important thing that you have to remember here, they will put on annual screening, but initial colposcopy, and the treatment less than CN2 is not treated. Higher grade sin will be like same what we do national guideline, and no additional screening will be there. So screening will be according to age of cessation from screening will be according to national guideline. So in my opinion, this initial colposcopy has been added new in the guideline. In previous guideline, what I remember, annual screening was there. So just you remember only one line from this, that when if the patient comes HPV positive, you have to do initial colposcopy, and you have to put this patient for annual screening for cervical sample. Okay, so this only
So less than sin 2 means include sin 2 also and sin 1?
no, it is only sin 1 only. Actually, what they say, Shaishta, that because of their HPV positive and immunosuppression thing, so actually this patient, if the cervical abnormality is there, their clinician, they do over treatment. So therefore they have put it there like less than sin 2, that means sin 1, you should not treat them. It is according to the normal patients only.
In routine guideline also sin 1 not treated. Only
Yes,
sin 2
not
and
treated.
sin 3.
Yeah. So because they very clearly say, because of their HIV status, people clinician over treat them. So these HIV patients, they should not get any over treatment. Okay. Now, this is all update about colposcopy guideline complete. I have put all important possible thing. So from my side, I have tried to make it almost 100%. No important thing has been missed from new guideline. Now, some questions are, something is important. This is the last part, just I'll be taking 10 minutes more. So it is the HPV vaccine update in 2019. Why I have put it here? Because this question was asked in part 3 exam last year about HPV vaccine update has come in the exam. So it is important you people to know. And also it is important for part 2 people, everything is important, but for part 3 also it is very important. So what things is there? So usually, so HPV vaccine, this is from the strategy. HPV vaccine, this is for part 2. Actually it is developed from virus like particles or VLP. Okay, it look like viron, but they do not contain any DNA, therefore they have got no infective property. So from this line, part 2 people may get any question. Previously there are available vaccines are two types: Gardasil quadrivalent, that will against 6, 11, 16 and 12, and Cervarix is bivalent 16 and 18. Previously they used to use this Cervarix, but now they are using this Gardasil, that is a quadrivalent vaccine. Okay, so this is just some initial information. Now this part, what you have to remember. So from September 2019, all 12 and 13 years old boys and girls, that is 8 year of school, that is 8th standard, like our kids in India in 8th class, so they will be 12, 13 years. So according to NHS the vaccine program, so they will get HPV vaccine. So what is new thing in that? So new thing in that is before September 2019, only girls were getting vaccine, but now both girls and boys, they are getting vaccine at 12 to 13 years of age, that is school standard 8. Okay, this is new thing. So this is important for part 2 people. So how the HPV vaccine helps? It protect against cervical cancer, it protects against some mouth and throat or head and neck cancer, it protects against cancers of anal and genital areas, it also prevents from warts. Why warts? Because warts are caused by HPV 6 and 11, and this Gardasil contains 6 and 11 strain. So this is the protection HPV vaccine can do. Basically every part is important for 2 and 3 both people, because it comes as a viva also. Okay, so this is the protection it does. Now this part I have already explained. So both girls and boys, they will receive routinely first vaccine at school year 8. Usually 2 doses are given. Second dose will be given 6 to 12 months after first dose. Okay, so these are the 2 doses are given. Apart from this, those people who miss their vaccination, okay, something had happened and they didn't get their vaccination, so in the NHS they could be vaccinated up to their 25th birthday. Okay, so they can get it if they miss. Then according to National NHS HPV vaccination program, so they are giving vaccine. This is the Gardasil, that is the quadrivalent vaccine that will protect against 6, 11, 16 and 18. And 16 and 18 you already know, these are the most probable cause for cervical cancer. More than 70% of the cervical cancer will be caused by this. So it causes protection for them. And 6 and 11, it is responsible for 90% of the warts. So Gardasil will protect girls and boys against cervical cancer and also genital warts. Then again, it is important for 2 and 3 both people. HPV vaccination, it will not do any protection for any other infection that can spread from sex, like any chlamydia, gonorrhea, anything. So and it is not an contraceptive also, so you have to explain them safe sex practices like condom and contraception, you have to explain them. Okay, so this is again important. Then this part has again newly added. So what they say, trans women, so this was not there in previous, this is update in 2019. Trans women, the people who assigned male at birth, that means they born as a male, now they have converted to female. Okay, they are also eligible for this HPV vaccination. Fine. This is new thing. Another new thing, trans men. Previously they were female. Now they have converted to male. They are also eligible with other men and under 45 years of age. Okay, so this trans women and these trans men, they are eligible for HPV vaccination in the national NHS HPV vaccination program. This is new update. Again, okay, so this trans men, if they have already got their HPV vaccination, because they were female, they were female at birth. So when they were female and they have got their vaccination, then why the new then now they have converted to men, so no further doses will be required. Why? Because when they were girl, they have already got their vaccination. So this part has been newly updated in 2019 September. This part again, so usually a series of 2 injections are given. They are given in upper arm. Okay, upper arm. You may get this in SBA also. And if the patient is more than 15 years of age, because under 15 they miss their vaccination, in that particular situation, number of dose it will be 3. So they would be given 3 doses. So in 3 doses, first when second dose will be given first month after first dose, third dose will be given 12 month after second dose. So if it is 3 dose, then second dose will be after first month, third dose will be after 12 month of second. Okay, so if the more than 15 years of age,
Ma'am, it is after 12 months or within 12 months?
within 12 months of second, within 12 months of second dose, within 12 months. Like
Okay, ma'am. Ma'am, in our country, we give it within 6 to 12 months, that dose.
I'm not aware of that, because whatever doses I have given, I have usually given 2 only.
Okay, ma'am.
Okay.
Just 0.16 month like this.
Okay, so yeah, I'm not aware of it. What is done in India, I'm not aware of it. Okay. So that
Okay,
knowledge
ma'am.
is India knowledge is not updated now. So this is UK knowledge for exam. So in if the person, if the child is more than 15 years, you have to give 3 doses. Second dose will be 1 month after first dose. Third dose ideally within 12 months. And I don't know within 12 means what. It is the same what that they have written on the NHS website. Okay, so just remember, you have to know this only. Again again new update, this is again a new update. So those men who have got sex with men, MSM, trans men, trans women, if they are eligible for vaccine, and they will need 3 vaccine if the again age is more than 50. So in this guideline, even this all males, they are giving vaccine. Even those who are having sex with men also, they are getting vaccinated. This is new update. Okay, so this is all about update of HPV vaccination. So it is important to know. If any one of you have got any question with regards to this, can ask me, because you will get, but you will get question, may get question from this vaccine part also. Any question, part 2, part 3, any people? Okay, so if there is no question, then very good. So this is again, I have just put this again, copied from internet only. So they will be given first dose at school year 8, and they will be given second dose 6 to 12 months later. Okay, second dose, And HPV vaccination is offered to boys in the school in 2019 that I just told. And if the person who is there who are doing sex MSM man is there, they will get vaccine at gum clinics. Okay, so this I just got just for visual memory I have put. Now with this,
Ma'am, MSM, men sex men can take vaccine under 45